fantastic session.
Yes,
Go ahead. Yes, go ahead. Thank you.
Sorry for the delay. Good evening, faculty, delegates, and all the postgraduates. Welcome to the masterclass session. I am Dr. Siri Kandavar, Assistant Professor in the Department of Anesthesiology, KS Hegde Medical College. Along with me, the co-hostess, Dr. Murli Shankar Bhatt, Assistant Professor in the Department of Anesthesiology, KS Hegde Medical College. We, on behalf of the organizing committee, PG Excel 2021, would like to extend a warm welcome to all our delegates and faculties. Before we begin, first let's move on to the rules of today's online masterclass. All audio should be kept in silent mode while the faculty is speaking. When a PG is asked a question, he or she should unmute and answer. If another PG wants to answer or knows the answer, they will have to raise their hand. One of us will allow you to answer. If the spectators have any doubts, questions can be asked in the chat box. Also, when you log in, please type your name and log in. So before we start, let's move on to the first masterclass of today's evening session. Is Drugs by Dr. Anand Banghera and Dr. Sudesh Kannan. First, let me introduce the speakers of today's first masterclass. Dr. Anand Banghera is a professor and former head of the Department of KS Hegde Medical Academy, Mangalore. His special interests are difficult airway, regional anesthesia, and teaching basics in anesthesia. Sir has many awards and achievements. He is a chairman of All India Difficult Airway Association Bangalore chapter, National Vice President of All India Difficult Airway Association. Dr. Sudesh Kannan. Dr. Sudesh Kannan is a professor of anesthesiology from Bangalore Medical College and Research Institute, Bangalore. He is an associate editor of Indian Journal of Anesthesia, editor of Karnataka Anesthesia Journal, and president of ISA Appreciation Award 2019. He has many publications in national and international journals. He has presented in many state, zonal, and national conferences. Over to you, masters.
Thank you, Dr. Siri and Dr. Murali Shankar Bhatt, for that nice introduction. I hope you can see my screen. You can hear me, and also you can see me. Is it Dr. Sudesh?
Yes, sir. Good evening, sir.
You can. I hope you can see me and you can hear me.
Yeah, yes, sir. Yes, sir. Yes, sir. It's very clear.
I think you can continue. Yeah. In this particular session of today's master class, we are planning to discuss the commonly used drugs in anesthesia. As we all know that there are lots and lots of drugs in anesthesia, including emergency drugs. It is practically not possible to cover all the drugs in this scheduled 1 hour. So what myself and Dr. Sudesh Kannan is planning is that we can discuss only few sample drugs. That is, we are planning to discuss one drug in each group of drugs, like one induction agent, maybe one muscle relaxant, and one inhalational agents. So drugs in anesthesia in exams is, especially in Viva, is the major part of the discussion. Many a times by the examiners, when they give you a drug, it is the point to initiate the discussion on other topics, including management of emergencies and all. So whenever you are discussing the drug, though there is a format to discuss the drug, you are supposed to cover the clinical important aspects of that drug. Maybe in the order that you are supposed to drug, but you you should not miss the important clinical aspects of any particular drug. That is very, very important. So whenever you are given with a drug, you have to narrate a drug in this order. First, you should tell what is it and what group it belongs to. Okay. Then you can initiate the discussion to describing it in the forms of mentioning one hallmark feature or the brand character of the drug. Like, for example, if you have been given with the propofol, you should start the discussion like this is the standard drug for daycare anesthesia, like this, so that it will give you a very good starting point for your discussion. Then, as the standard format goes, and if there is any important history aspects, like who discovered it, like if you are talking about tap and turn, if you mention about Dundee and Lundy, who are the two important discoverers of this and who have done a lot of drugs, so that will give you more weightage. Then you have to tell how is it available? Is it in powder form? Is it ampoule or vial? And most importantly, how you have to reconstitute, what solutions you can use to reconstitute this drugs, because it is very, very important. Then the mechanism of action, on what receptors it acts, whether it inhibits, potentiates, whatever it is. Then important pharmacokinetics, mainly talking about the metabolism and the excretion. Metabolism and excretion both are important as anesthesiologists, because you have to take care whenever there is a patient coming for anesthesia with renal disease or hepatic insufficiency, all those things. Pharmacodynamics, the actions, the important actions on the vital system, cardiovascular system, respiratory system, central nervous system, hepatobiliary system, like this. Advantages, what are the advantages and if there is any disadvantages. Then dosages in adult patients as well as in pediatric patients, and in what type of patients the dosage has to be modified and or altered. Important side effects. This is very, very important. Okay. In addition to knowing the effects, you are supposed to know the side effects, because it is more important when not to use, in addition to knowing when to use this. Okay. Important drug interactions. Okay. Drug interactions when you, in the sense when you prepare or when you administer the drug, and interactions when after administering the drug. Important contraindications, as I said. Then indications, common indications and clinical uses. And finally, if there is any new things or any new updates regarding that particular drug. So that is the pattern that you are supposed to narrate a drug. So my co-faculty, my dear friend, Dr. Professor Sudhish Kannan, who is the professor at the prestigious Bangalore Medical College, he will select one sample and he will narrate as a sample how to explain a drug. Over to you, Professor Dr. Sudhish Kannan.
Thank you very much, sir. Thank you for your kind introduction, and as well as thanks for this opportunity. I thank the entire faculty of PGXL 2021, the organizing team, for giving me this wonderful opportunity. So, without wasting much of your time, I would share. Can I go ahead with sharing the screen so that it will be easy for them to follow?
Yes, sir. Yes. Can you see that? I think I have put already the slides. Can you see? I thought you could see the. Are you able to see my screen?
No, sir. You are not shared the screen.
No, sir. You have to share the screen.
I thought all this time I was sharing my screen. Okay.
Never mind, sir. I'll share the screen.
No, can you see now?
No, sir.
Not at all. Okay. Right. I think Sudhish, you can do if you can.
The team should allow me to share the screen, sir, because they have allowed only this one whiteboard, which is not sufficient. Actually, they should allow me to share my screen.
Oh.
Even logistics.
Sir, you can share, sir. You can share it.
No, the problem is shows share only whiteboard. Advanced, if you see, music or computer sound only, content from the camera, slides as virtual background. Okay. It's not, share screen is not possible. Anyways,
Sir, you can share, sir. Just
No,
try
no.
once more because it is allowed because you are a co-host.
Share screen option.
no, the thing is, if I click on share screen, it comes as only the whiteboard. It's not
Share
allowing me to share my desktop screen.
Yes, sir. See now someone shared. Who's this?
Now is it coming? Now I am doing.
Bangera, sir. Yeah.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. You can open.
Now can you see?
Yes, sir. Yes, sir. Yes, sir.
Yeah. Okay. Sorry for that.
It's no issue, sir. No issue, sir. Not a problem, sir. We should not waste much of the time. That's the only issue. That's all. Before, shall we go ahead, sir? Sir, can you please move the slides? For me?
There
Wait,
is no problem.
yeah.
I'm unable to. Yes. So this is what I was describing. Okay, the different steps. I think you can see now, Sudesh.
Yes, sir. We'll go ahead with the next slide.
Yes. Sir. Yeah, Sudesh, you can continue.
Yeah.
Can you see?
So,
Can you
yeah.
see now, Sudesh?
Yes, sir. Yes, sir. Yes, sir.
Yeah.
Good evening, all the esteemed participants. As Bangera sir described the way how the drug has been discussed, so I'll be starting to do a small this one. What do you say? A small prototype by describing one of the drugs. Because ketamine was not included in the list of drugs, I'm going to present that. So when we start off with drug, so we start with the physical characteristics. So ketamine belongs to phencyclidine group of drug, and the chemical name, it's a phenyl drug with both R and S enantiomers, and it is available as both vials and ampules. And the concentration in both vials and ampules is 50 mg per ml solution. This is in India, whereas in other places even 100 mg per ml solution is also available. So when we're discussing about the history, it was first introduced in humans in 1965 by Carson and Domino. Before that, it was also used in animals in 1952. Since it was first used in 1965 in humans by Carson and Domino, it was invented much before that. And important thing is it is actually preserved in a solution. It's available as a clear colorless solution which can be preserved at room temperature, and it has got benzethonium chloride as a preservative. The importance of this benzethonium chloride is that it can induce allergic reactions. It's a PABA derivative. It can induce allergic reactions in certain susceptible patients, and also it is also known to be causing neurotoxic when you expose naked nerves to this particular compound. The physical characteristics, as sir was discussing, it is a white crystalline powder which is partly soluble in water. The pH is around 5 to 4.5 to 5, and with a pK of 7.5, and it has got very high lipid solubility. Next, sir. It has got very high lipid solubility, and this drug, if you go through the pharmacokinetics, so when you think about pharmacokinetics, you just imagine once the drug is given. See, when the drug is given, it can be given in multiple routes. Most commonly, what we use is intravenous route. But other than that, there are other routes like oral, subcutaneous, sublingual, various routes, intramuscular. So many routes are available. But when we discuss about anesthetic drugs, it's always understood before without telling that it is intravenous. So it has got a very high first pass metabolism, hence bioavailability is available, is high only through IV, whereas oral and this one has got very less bioavailability. Protein binding is only 12%. See, what you should understand is when a drug is injected IV, what will happen to the drug when it passes through the blood, and what is the time taken to reach its target site, and then how long it stays at the target, where, and then from there how is it removed from the target to the other parts of the body, and how it is ultimately excreted. This is the skeleton when you talk about pharmacokinetics. So you start off with administration, and the protein, once it is injected into the blood, it actually binds to protein, and then it gets circulated and it reaches the brain. So protein binding is 12%. That means most of the drug is freely available. Henceforth, the onset of action is almost immediate, within 1 minute from the time of IV injection. And the cessation of mechanism of action is by redistribution, and redistribution half-life is 11 to 16 minutes. That means after once you give within 11 to 16 minutes, it gets eliminated from the brain, and it is mainly primarily metabolized in the liver by N-demethylation to form norketamine. It's not a very active compound. It has got only 10 to 20% of the activity of parent compound. Only it produces only analgesia, but not amnesia and anesthesia. It has got a very high rate of hepatic clearance. So that's why its elimination half-life is 2 to 3 hours. Now, what is important at this point regarding ketamine is has got very less protein binding, and it is highly extracted drug from the liver. So therefore, the metabolism of this particular drug is highly dependent upon the blood flow to the liver, because it's highly extracted from the blood into the liver cells. So any damage, anything which causes a decrease in blood flow to the liver can straight away reduce the metabolism of ketamine. So coming to the next is mechanism of action. It is NMDA receptor antagonism, and the site of action in the CNS predominantly is the thalamoneocortical projection system. So when you talk about other peripheral areas in spinal cord, it has got a direct effect on the NMDA receptors in the spinal cord, as well as WDR region, that is wide dynamic range region, to provide analgesia and prevent long-term anti-analgesic effect. So this is about pharmacokinetics, and next is pharmacodynamics. When we talk about pharmacodynamics, three important organs: one is brain, heart, and kidney. After brain, heart, and lungs, and then subsequently kidney, liver, and other systems if there is any. So as we know, CNS, it produces dissociative anesthesia and also profound analgesia, and it is known to have some neuroprotective effect. But the problem with it is it increases the CNS blood flow and increases CMRO2. The CNS blood flow is disproportionate to the amount of increase in the cerebral metabolic oxygen demand, and it can also trigger epileptiform foci. It can increase muscle tone, peripheral muscle tone, as well as result in nystagmus and dilated pupils. So it can result in emergence agitation. Next we are talking about cardiovascular system. So we all know that by its effect is most of the time indirectly mediated through the activation of your catecholamine system or the sympathetic system, which causes increase in heart rate, BP, inotropy, chronotropy, etc. In addition, but its direct effect on myocardial muscle is myocardial depression. This is very important, because whenever a patient who has got sepsis or something, in whom there is already adrenal drain, that means somebody whose system is drained out, if you give ketamine in them thinking that it will increase the BP, it will cause a paradoxical fall in blood pressure. It also increases the pulmonary vascular resistance, and basically it is all by prevention of noradrenaline reuptake at peripheral level, also at a sympathetic stimulation at the central level. Next slide. So as I told, the respiratory effects, it's a potent bronchodilator, and it preserves the pharyngeal and laryngeal reflexes. So the examiner might ask, what are the implications of this? So there are two implications. One is it prevents aspiration, but at the same time, even the presence of a slightest amount of secretions, because the patient is in various varying levels of depth of anesthesia, the patient can, these secretions, if they are present, it can induce laryngospasm or bronchospasm. So that is one of the, it's a paradoxical effect. And the other effect is increase in the secretions such as lacrimation, salivation, etc. And now this is about pharmacokinetics and pharmacodynamics. Next, users advantages. Users, most of the time, it is a induction and maintenance of anesthesia, and specifically in certain conditions like congestive cardiac failure, cyanotic congenital heart disease, and in bronchial asthma patients, where it has got the sympathetic activity has got a beneficial effect. And also, because of its profound analgesia, it provides pain management, both acute and chronic pain. And the recent most this one is regarding antidepressant. It's used as an antidepressant. Dosage has been as shown by as shown in the slide, varies depending upon the route of administration, as I described. So you can go through the books for the dosage, and the side effect is rise in ICP, secretions, and sometimes hepatotoxicity can occur due to prolonged infusion. So what are the contraindications? Already, if you know the pharmacodynamics, it's very easy. So you talk about head injury, intracranial space occupying lesions, ischemic heart disease, stenotic lesions like mitral stenosis, aortic stenosis. And in neonates, there is a recent caution regarding apoptosis of neuronal cells, and hence there is a word of caution while being used in neonates. So next. So coming to important drug interaction, as I told earlier, because of its metabolic, it is because a high liver uptake drug, then any factor affecting blood flow can delay its metabolism. So for example, if you are using especially halothane after ketamine induction, invariably the halothane will reduce the blood flow of liver, thereby prevent ketamine uptake, and it can prolong the duration of action of ketamine. And whenever it is used with other IV agents, it can cause a synergistic effect in prolongation of action. And use of benzodiazepines and droperidol has been found to reduce the psychomimetic effects and hemodynamic effects of ketamine. It can blunt. So recent advance with respect to ketamine is that there are many trials regarding its use as antidepressant. So if you just go through, I've almost touched upon everything.
Yes, Professor Sudesh has explained in detail like how a drug has to be explained with the example of ketamine. So we have around 10 participants. We have Dr. Ravi Karan, postgraduate from Kidwai Institute, Bangalore, Sujita from Rangaraya Medical College, Kakinada, Akash from JJM Medical College, Davangere, Charan Raj from Mandya Institute of Medical Sciences, Mandya, Akansha Sharma from MGM Medical College, Navi Mumbai, Kinjal Shah from BJMC Medical College, Ahmedabad, Dr. Tejal from K.S. Hegde Medical College, Medical Academy, and Dr. Aditya from K.S. Hegde Medical Academy. So with that example and with that pattern explaining you to how to explain, we shall ask you PGs to describe some of the drugs. First, we shall discuss about the induction agents, and this is the gold standard induction agents. Can anybody opt to discuss about this particular drug? You can please unmute and put
Yes,
on and go ahead. Yes, please. Yes,
Sir,
go
good
ahead.
evening, sir. Yes, sir. Thiopentone sodium. It is a thiobarbiturate. It is available in yellow amorphous powder, and it is in a vial containing 500 mg or 1000 mg, and it is highly alkaline when mixed with normal saline. The pH is around 10.6. So usually preservative free is available. Once reconstituted, it should be used within 7 days.
You said that its pH is highly alkaline. What is its clinical importance?
Because it's highly alkaline, when we give it through intra-arterial, it forms crystal when it mixes with blood, and it results in vasoconstriction and pain in the injection site,
Yes.
tissue necrosis. And when we reconstitute it with solutions like ringalactate, it will further crystallize.
So you are not supposed to use any acidic solutions for dilution. Yes, go ahead, please.
Mechanism of it was discovered by Ernest H. Wallier and Donnell. The feature of the mechanism of action is acts on the GABA receptor. It has GABA mimetic and GABA facilitatory action. In lower doses, it causes GABA facilitatory, where it helps the GABA to a longer time to react with its receptor, and chloride channels will open up, creating hyperpolarization. In higher doses, it will be GABA mimetic.
Yes. Can you explain its action on the central nervous system, please?
Yes, sir. On the central nervous system, induction doses, it will produce sedation. The drug has redistributive properties, that is, it will be distributed to the highly vascular organs like brain. Around the brain arm circulation of 10 to 15 seconds will take place.
Yeah, this
After
is
the
the
patient gets
ideal drug
induced,
for neurosurgeries and any patients with head injuries. Why it is the ideal
yes,
drug?
sir.
What are the advantages?
It helps in reducing the cerebral ICP. So the cerebral perfusion pressure increases because of the decrease in ICP and has little effect on mean arterial pressure.
Yeah, it can
So the
produce what
main
is called as a Robin Hood phenomena, is it not? Can you
yes.
tell what is this Robin Hood phenomena?
That is, it will help in diverting the blood from the from the ischemic areas to the non-ischemic areas. So it helps in focal ischemia. It is a cerebroprotective agent in focal ischemia, but it is not a cerebroprotective agent in global ischemic changes.
Okay. Any comments about its analgesic action?
It is an anti-analgesic drug. So lower the induction doses, it causes pain, and it can also lead to laryngospasm in less than the induction doses.
So you have to use the analgesic along with this, in contrast to drugs like ketamine, is it not? Where you need not use a
analgesic agent.
Itself is a potent analgesic. Yes, go ahead.
Okay. Coming to the cardiovascular system, it causes a decrease in BP by peripheral vasodilation and pooling of blood.
Okay,
and,
can you, because of the paucity of time, I'm just doing a fast forward. Can you tell us the clinical uses of thiopentone sodium?
It can be used as an induction agent. It can be used in refractory seizure cases.
Yes.
It is used in cerebral protection cases in neurosurgeries, and it can be used to.
Yes.
That's its uses.
For narcoanalysis, yes, that is a very excellent. Now, can you compare thiopentone with propofol? Only with very few points, only important points.
Yes, sir.
Yeah.
Propofol can be used as a daycare anesthetic agent, whereas thiopentone cannot be used because the recovery from it takes about 24 to 36 hours in case of thiopentone. And propofol, the action is on the GABA beta receptors. And disadvantage of propofol is that propofol, 1% of propofol is there, 10% soya bean oil, and 1.2% of egg lecithin will be present.
Yes,
so
that's fine. But propofol, you all very much, you like this propofol very much nowadays. You people don't use thiopentone at all. That means, what is the advantage of propofol? The brand character of propofol.
It is used in daycare anesthesia, and
that word should always come. If you talk about propofol, that word should always be there. Yes, why? Why it is the ideal agent for daycare surgeries?
The recovery from the drug, it is highly.
No, in comparison to thiopentone, how the action of thiopentone is terminated, how the action of propofol is terminated.
Yes, sir. This is redistribution and it goes into the fat thiopentone, whereas propofol, it is hydroxylated into glucuronide, quinol, and phenol compounds. So it is excreted via the kidneys, and it's water soluble, and it's excreted via the kidneys.
Yeah, in simpler words, the action of thiopentone is terminated by redistribution, whereas the action of propofol is terminated by elimination. That is why when you give thiopentone, patient may be drowsy for a little more time. Okay, that is very excellent, Dr. Sujita. Dr. Sudesh, you want to add anything? Can you go to next?
Yeah, two questions. What they always have to remember, students, is how is thiopentone diluted? That is one of the most common questions asked by examiner's favorite question. How do you dilute it? So the target is to dilute it to 5% solution. So if it is 500 mg, you add 10 ml of normal saline. If it is 1 gram, add 20 ml of normal saline. So make it 5% solution. And when you take it to administer, you have to administer it as 2.5% solution. So this is one of the important things what you have to keep in mind. And second thing is, how do you treat intraarterial injection is the next question. That is one.
The cannula.
Yeah.
The cannula has to be left in place, stop the injection, and we have to dilute it with sodium, normal saline 0.9%. For pain, papaverine of 40 to 80 mg can be given.
Yeah, lignocaine you can give to reduce pain.
Or lignocaine, 0.5% of 5 mg can be.
Yeah, you can give, and along with that, you can use the papaverine for local viral treatment. Okay.
Okay,
Then,
that's very good. I think we can go to the next
yes, sir.
group of drug, muscle relaxants. This is succinylcholine. Okay, though it has got many side effects, many contraindications, still one of my favorite drug. Anybody wants to take this?
Yes, sir.
Yes,
Yes.
Dr. Tejal, is it?
Yes, sir.
Yes, please go ahead.
This is succinylcholine. It is a short-acting depolarizing neuromuscular blocking agent. It is available in vial, which is amber colored, and it is available as 50 mg per ml or 100 mg per ml. 10 ml vials are available. This can be given IM, IV, and even as an IV infusion use. If it is used as IV agent for an adult, it will be 1 to 1.5 mg per kg. IM dose will be 3 to 4 mg IM dose. Then, sir, for this, sir, effects, it acts on phase 1 blockade. It will act on the succinylcholine is formed of 2 acetyl coenzyme A molecules joined together. It will act on the acetyl coenzyme A nicotinic receptors present at the motor end plate, and it will
In
cause
simpler words, because it is a depolarizing
Yes.
agent, so it acts by persistent depolarization. As you
Persistent, yes.
said, it is 2 molecules of acetylcholine.
Acetylcholine.
Is it not? Yes, go ahead.
It will cause persistent depolarization, sir.
Yes.
Now, the onset of action, sir, will be within 30 to 90 seconds IV, sir. And
Yes.
if it is IM, then we can expect it to be from 2 to 3 minutes, sir. And the duration of action, usually IV, it will be less than 5 minutes, sir. But in cases of patients who are having pseudocholinesterase deficiency, the duration of blockade can last for a long period of time, which is succinylcholine apnea, where it can last for an hour or more than an hour and a half.
Yes, Tejal, you are talking about lots of disadvantages. Yes, I know there are a lot of disadvantages. What is the advantage of succinylcholine? Is there any advantage?
Yes, sir. It's a short-term muscle relaxation that can be used while intubating, especially in case of difficult airway. We can use it for rapid sequence intubation, sir.
Yes.
For full stomach patients.
Yes,
it is
very good. Then
especially-
what are the disadvantages? Any side effects?
Yes, sir. First is in case of brain, sir, it increases the intracranial pressure, sir. It increases the intraocular pressure. It will also increase the, it will cause muscle pains, sir, because of the rhabdomyolysis.
Okay.
And it can cause muscle pain as well after the operation is done.
So where it is contraindicated?
It is contraindicated in case of closed head injury, sir. In case of major burns, if the patient is having Guillain-Barré syndrome, or if there's massive trauma, crush injury, myopathies, it is always contraindicated, sir.
Open eye injuries,
Yes,
head
sir.
injuries.
Open eye.
Is
Open
it?
eye
Very
injuries.
good, very good.
Sir.
Yes. Can you now compare these 2 drugs?
Yes, sir. Atracurium, it is a benzyl isoquinoline group. Then it is available in vials itself and ampules.
Yeah.
Vials,
You compare and contrast, Tejal.
yes, sir.
Compare and contrast between succinylcholine, a depolarizing muscle relaxant,
Yes, sir.
intermediate acting, non-depolarizing.
Non-depolarizing muscle relaxant.
Yes.
Then atracurium, sir, we can only give IV as compared to succinylcholine, where we can give IV, IM, and infusion can be given as well. It causes muscle irritation if we give IM, sir, atracurium. Atracurium is also known to cause H+ histamine release, sir, as compared to succinylcholine.
Yes, because of the lack of time, we shall discuss only important things. What is the advantage of atracurium? What is the good things that you...
Laudanacine is a metabolite, sir.
Yeah.
It
Good things.
causes a reduction in the
Advantage.
seizure threshold.
Advantage. Good
Advantage.
things. Yes, yes. Good things first, bad things next. Yes.
So, it won't cause muscle pains
No, regarding
as
its
compared to
metabolism,
succinylcholine.
Tejal.
It is esterase
Yes.
Hoffman elimination,
Yes.
sir.
What is this Hoffman's elimination?
It does not rely on any organ for its metabolism, sir.
Can you tell me what exactly is Hoffman's elimination?
It is in case of Hoffman's elimination, sir, it will be esterases are involved, sir,
Yes.
for the metabolism.
pH dependent, non-enzymatic, chemical self-degradation of the drug.
Yes, sir.
Is it not? Okay,
Yes,
so that is why it is good in patients with renal diseases as well as. So you are talking about some disadvantages. What are the disadvantages?
It causes histamine release, sir. And also in case of, it also releases laudanosine, which is a metabolite. It can reduce the seizure threshold and can lead to seizures, sir.
Yes, very good, Dr. Tejal. Dr. Sudesh, you want to add something?
Nothing, sir. Actually, they have covered almost everything.
Yeah, she has covered. I think we can go to one of the volatile anesthetic agents. Yes. Anybody wants to take this? Isoflurane. Dr. Akansha Sharma is there? Dr. Akansha. She wanted to discuss about this particular drug. I think she's okay. Anybody else wants to tell some salient features?
Good evening, sir.
Yes.
Sir, isoflurane, sir.
Your name?
Sir, Ravi Kiran.
Yes, very good. Yes, please go ahead. Please go ahead.
Sir?
Yeah, please go ahead.
Sir, it is isoflurane, sir. Chemically, it is ether derivative.
Yes.
It is a fluorinated ether. It is a clear, colorless solution, pungent in odor. The property saturated vapor pressure is 200, sir, and boiling point is 50 degrees Celsius. And
what are the advantages? You prefer this drug always, no? Maybe you like this next to sevoflurane. Is it not?
Yes, sir.
You always prefer isoflurane. Why do you prefer? What is the advantages of this drug?
So it is comparatively cardiostable, sir.
Yes,
it is not arrhythmogenic.
Is there any theoretical disadvantage as far as cardiac actions are concerned? Something? You know what is coronary steal phenomena?
It can cause coronary steal phenomena, sir.
What exactly is this?
Yes, sir. It is the blood. The blood supply is diverted towards the normal myocardium.
It produces coronary vasodilatation of the normal vessels. The affected areas, the vessels, they cannot dilate anymore further. Is it not? So that is a little disadvantage, maybe little more theoretical. Okay. Any disadvantage of isoflurane, Dr. Ravi Kiran?
Sir, it is pungent in odor, so cannot be used as an induction agent.
Not that it cannot be used, but it is not very ideal, especially for pediatric patients. Is it not? Okay.
Yes, sir.
Okay. Okay. Now you said that it has got some advantages and this. Can you compare with this your most favorite inhalation anesthetic agent? That is the sevoflurane.
Sevoflurane, sir, it is ideal for inhalational induction agent, sir.
Yeah.
The other advantage is the metabolism compared to isoflurane. The sevoflurane undergoes only 0.2% of metabolism.
What is that? Any metabolite which is very important?
Yes, sir. It can react with soda lime and can form compound A, sir.
Yes. What is that metabolite?
Trifluoro.
Fluoride moiety. Fluoride moiety. Is it not?
Yes, sir.
Okay, the idea, best advantage of sevoflurane is fast induction and fast recovery.
Fast.
What is that? What character of this makes it as the for fast recovery as well as fast induction?
Because of the low blood gas solubility, sir.
Low blood gas solubility coefficient. Okay, okay. Any other disadvantage of sevoflurane?
When used with low flow anesthesia, it can form
In the close
compound A, sir.
Okay. Any other thing? Because it produces fast recovery in pediatric patients. Any other problem?
The emergency, it can cause emergency delirium, sir, because of
emergency.
fast in, fast out.
Emergency delirium. Okay, that's very good. Dr. Sudesh, anything you
Yes,
want to add, or you want to ask some questions for Ravi Kiran or anybody else?
Yeah. With respect to isoflurane, sir had discussed already about coronary steal phenomenon. You should always keep in mind like other cardiac effects of this one. That is, it causes what is a preconditioning of cardiac muscles, preconditioning of cerebrum, so that many times the patient who is receiving isoflurane, many times the myocardium and the brain are protected from ischemia due to decrease in perfusion. So that is one of the important aspects. Other than that, recovery time and hepatotoxicity, these two things. And with respect to sevoflurane, renal toxicity.
Okay. Shall you go to the next drug?
Yes, sir. Yes, sir.
Yes. We shall go to opioids. Maybe we will be able to discuss one or two drugs. Yes. Anyone wants to take this?
Hello, sir.
Yes.
Good evening, sir.
Yeah, please. Can you please tell your name?
Sir, Charan, sir.
Yeah, Charan from Mandya Institute.
Mandya. Yes, sir.
Please.
Sir, it's a morphine.
Yeah.
Naturally occurring opioid analgesic, sir.
Yes, very good.
It's history-wise, it is first active alkaloid, sir, which is extracted from poppy plant.
Yes.
And formulation, mainly, it can be used as a intravenous, intramuscular, peroral, and rectal, epidural, intrathecal.
Yes.
Subcutaneous also can be used.
Yes.
It is available as a clear colorless solution, sir, which is containing 10, 50, 30 milligram per ml as morphine sulfate. It is available as tablets also, sir, in the range of 5, 10, 30, 60, and 200 milligram of morphine. It is available as a syrup also, and suppositories also, sir. Suppositories containing 15 to 30 milligram per ml. Coming to the mechanism of action, sir, it is agonist at opioid receptors like mu and kappa opioid receptors, sir. Mainly, it interacts with the presynaptic GABA inhibitory protein receptors.
What are the advantages, Charan, of morphine?
Sir, mainly it is a advantages, sir.
Yes.
Sir, it is mainly used as an analgesic, sir. It is a potent, highly potent analgesic, sir.
It has other uses also, is it not? Because of its other systemic actions. What are the other uses of morphine other than as an analgesic?
Sir, it can be antitussive also. It can be used as an antitussive.
Yes, any cardiac conditions, is it?
Cardiac left ventricular failure, sir. Treatment of left ventricular failure.
Yes. What about myocardial infarction?
Yes, sir.
Yes. What is the advantages in a patient with acute MI?
Sir, mainly it reduces the intensity of the pain, sir.
Yes, it is analgesic. Yes.
Analgesic.
Then
and also
it produces venodilatation. Is it not advantageous?
Vasodilatation. Yes, sir. Yes, sir.
Yes, it decreases the preload. Is it not?
Yes, sir.
Okay. Any other advantages?
Sir, in case of palliative care also, again, it is can be used, sir.
What is the duration of action of oral morphine, Dr. Charan?
Sorry, sir. Oral
duration
morphine,
of action of a dose of morphine, oral morphine. That means how often you are supposed to give.
Sir,
how often the patient is supposed to take.
It is 4 to 6 hours, sir.
Yes. So it has to be given every 4 to
6 hours.
What is the common side effect of oral morphine? When you are giving it for patients with the cancer pains or any other chronic pains?
Sir, late respiratory depression, sir.
That is the, okay. Any other common side effect?
Constipation.
Huh?
Constipation. Constipation.
Yes. Constipation is the very common side effect. Now, can you compare this with the other drug, the most favorite drug of you people now?
Yes, sir.
That is
Fentanyl.
Fentanyl, yes. Compare
It
and
is a
contrast.
synthetic.
Compare
Sir, it
and
is a
contrast.
synthetic. It is synthetic, sir.
Yes.
Synthetic opioid.
Yes.
And it is a phenylpiperidine derivative.
Yes.
Very good.
It is also like highly potent.
Yes. How potent is this when compared to morphine?
1 to 10, sir.
It's around nearly
100 times.
100 times. 100 times.
100 times
Yes,
more
sir.
potent.
100 times.
Morphine. Okay. Any advantages?
Sir,
It is short acting. So what is the advantage?
sir, intermediate acting, sir.
Okay, short intermediate. What is the advantage then?
And sir, there is no histamine release in fentanyl, sir. And also it
Can be given as infusion, is it not?
Yes, sir. It can be given as an infusion.
Can be given as infusion or intermittent doses. Okay. It can
sir.
also be used as a induction agent, especially in cardiac surgeries.
Cardiac surgeries.
Unstable cardiac. Dr. Sadish, you want to ask something?
Yes, sir. What is the peculiarity of respiratory depression due to morphine?
Sir, it is basically late respiratory depression, sir.
Okay. It's not only late. The respiratory depression can occur in two phases, like early respiratory depression.
Early
and
respiratory depression.
Early respiratory depression most often is due to dose overload, whereas late respiratory depression is due to the presence of active metabolite, inadequate excretion of
morphine 6-glucuronide.
Yes, yeah, morphine 3-glucuronide. It has got almost 50% of the morphine's parent activity. Yeah.
Yes.
So that is the problem. Okay. So that is with respect to morphine. That is one of the most favorite questions of all the examiners regarding late respiratory depression. And also, what is the dosage, like intravenous to epidural to intrathecal? How does the dose change?
Sir, morphine, sir, regarding fentanyl or morphine, sir?
Morphine.
Sir, it is around 0.05 to 0.1 milligram per kg body weight, sir.
Intravenous?
Intravenous.
Intravenous. When you go to intrathecal, what happens to this dose? Is it the same?
No, sir.
It should reduce, isn't it?
Reduce, sir.
It will reduce to 1/10 of the
1/10 of the.
That is because of its hydrophilic character. Because it is not soluble in. It is not a
lipid soluble.
Yeah, because of its less lipid soluble capability, the dose has to be reduced. Okay.
Yes, sir.
So at the same time, that is a one hindering factor. It's also less protein bound when compared to. So any as sir described already, it's very important to understand what do you say, every drug with respect to protein binding, with respect to volume of distribution, is very, very important to read each and every drug, especially the opioids. Okay, they might ask you in the exams because most of the mechanism of action and its the altered pathophysiological states will alter the duration of action because of its volume of distribution.
Yes, sir.
Right. And fentanyl produces a classical rigidity called as
muscle rigidity.
Woody rigidity.
What is it?
It's called woody rigidity. Woody rigidity.
Excellent. We shall go to next group of drugs, that is local anesthetics. Okay, who wants to take this commonly used local anesthetic agents? Whoever is answering, please unmute as well as put on your video. We want to see you also. Yes, anybody wants to take this? Dr. Aditya wanted to discuss. Dr. Aditya is there? Okay. Anybody else? Anybody else wants to discuss about lignocaine?
Hello.
Yes.
Yeah.
Hello.
Yeah, Aditya. Yes. Yes, go on.
Yes, sir. This is Dr. Aditya Sai from KSA Grade.
Yes.
I like to discuss about lidocaine, sir. It is first synthesized under the name of xylocaine, sir, by Swedish chemist Niels Lofgren. It was FDA approved drug in 1948, and it was first amino amide local anesthetic. and it is coming to its chemical structure. It is a tertiary amine, which is it is a tertiary amide, which is a derivative of diethylamine acetic acid. Coming to the mechanism of action, it alters the depolarization in neurons by blocking the fast voltage gated sodium channels. And it is available as a clear solution, clear colorless solution, and with the concentration of 2% solution of lignocaine hydrochloride with or without adrenaline. And the preservatives are methyl paraben, that is 1.7 mg per ml. And it also available as 2% lignocaine gel, 2% lignocaine, and it also available as EMLA, which is a white cream used to provide topical anesthesia prior to the venipuncture. It is 2%, EMLA is 2%, 2.5% prilocaine and 2.5% lidocaine. And it is available as 2% jelly, which is used for urethra. Coming to the pharmacokinetics.
No.
Any other
Can you tell me what exactly is this eutectic mixture?
Sir, it is a eutectic mixture is a white cream, sir. It is a mixture of local anesthetics, sir. It is it is used for venipuncture and split skin grafting, sir.
Eutectic mixture is one when in this mixture there is no chemical reaction. It is a mixture of 2.5% prilocaine and 2.5% lignocaine. There is no, and it inhibits the crystallization process leading to a melting point, which is actually lower than the melting point of the individual local anesthetic agents. That is what is called as a eutectic mixture. Okay.
Sir, it is available as 4% aqueous solution for topical application, and other 5% for suppositories, sir. Rectum and
it's also available as 5% ointment.
Yes, sir.
Then lignocaine gel, which is 2%, lignocaine viscous, a lot of preparations, and most important is lignocaine 5% heavy, which we are not using nowadays for some other reasons, like of rare incidents of neurotoxicity which occurred earlier. Okay. Now can you compare with this the bupivacaine, the commonly used drug?
Sir, it is both are amides only, sir. The thing is, one is intermediate acting. Lidocaine is intermediate acting, and bupivacaine is longer acting, sir. And compare it to, and one more is bupivacaine is high potency drug, sir. And when
what is the advantage of bupivacaine, Dr. Aditya?
Sir, bupivacaine has a less neurotoxicity, sir.
And more of cardiotoxicity.
More of cardiotoxicity.
And it has got in lower concentrations, it has got more of analgesic action.
Yes.
Is it not? Okay.
Yes, sir.
Right. So, what any major disadvantage is cardiotoxicity? How do you treat cardiotoxicity with bupivacaine?
Lipid emulsion, sir, which is
intralipid. Okay.
Yes, sir.
Okay. Okay.
Yes, sir.
We shall go to the next one, anticholinergics. Anybody want to take, or any other? Anybody want to take this? Dr. Akash from JGM Davangere. Dr. Akash, you are there? Okay, anybody else wants to take? We are running short of time. Okay, anybody just tell the difference between the atropine and glycopyrrolate so that we can wind up.
Hello, sir.
Yes, yes. Who is this? Dr. Tejal. Yes.
Sweetie Datta, sir.
Yes, yes, yes. Please.
Sir, glycopyrrolate normally it is available in a dose of 0.2 mg, and atropine it is available in a dose of 0.6 mg.
Yes, yes, yes. Okay. You can
sir,
see only your hand. Right. Okay. Go ahead.
Yes, sir. Sir, atropine doesn't crosses the blood-brain barrier. Atropine crosses the blood-brain barrier, and glycopyrrolate it doesn't crosses the blood-brain barrier.
Why is that? Why is that atropine crosses? Why not glycopyrrolate?
Because atropine is a tertiary structure, sir, and glycopyrrolate is a quaternary compound. So it is a bigger compound. It can't cross.
Yes. Okay. Okay. Yes. Any other difference?
Yes, sir.
Which
Atropine
has
first it
more?
causes bradycardia, and then it causes tachycardia. Whereas glycopyrrolate it directly stimulates the heart and causes tachycardia.
Okay. Which has got more anti-salicylic action?
Sir, atropine.
Atropine or glycopyrrolate?
Sorry, sir. Glycopyrrolate.
Glycopyrrolate, especially when it is given in the intramuscular form. Okay. What is the central anticholinergic syndrome, which is produced by which drug?
Sir?
Central anticholinergic syndrome.
It is produced by, sir, atropine only.
Atropine. Okay. Okay. There is no much time now. One of these emergency drugs, sodium bicarbonate. Can anybody want to take this?
Sir,
yes.
Sir, it is a chemical compound which is sodium and bicarbonate.
Yes.
Which it was FDA approved, which is indications include for cardiac conduction delays and QRS prolongation, sir. It is available as oral tablets, IV injections, and IV infusions, sir. And its the mechanism of action is the main therapeutic of sodium bicarbonate is increases plasma bicarbonate levels, which are known to buffer excess hydrogen ion concentration, thereby raising the solution of pH, sir. To combat the clinical manifestations of acidosis, and it treats metabolic acidosis, sir. And the dosage is like 0.3 into body weight into base deficit, sir.
Yes.
And side effects, adverse effects, it causes hypernatremia, increased sodium load, that is a headache, and nausea, vomiting, increased frequency in urination, sir. And there is this one rapid administration causes intravascular fluid volume leading to pulmonary edema.
Okay.
That's all, sir.
Okay, very good. There is a lot of other things. That's fine. But can you come now talk about this magnesium sulfate, which is one of the wonder drug?
Sir, it has numerous actions, sir.
Yes.
It is a blockade of NMDA, that is N-methyl D-aspartate receptor and calcium channel. It is a colorless solution, 2 ml magnesium sulfate, sir. Contains 50% weight by volume as HEPA hydrate, and which is 2.03 millimoles ionic magnesium, which is 50%. The normal range, it is 0.7 to 1.1 in plasma level, sir, millimole per liter.
Okay, what are the clinical uses of magnesium sulfate?
Sir, it is used for cardiac it is used in
any obstetric conditions is used?
Preeclampsia patients, sir.
Preeclampsia as well as to manage eclampsia also.
Yes, sir. And used for acute MI, cerebral edema, and it is as a tocolytic in premature labor, and
Okay.
it is also a treatment of arrhythmia and asthma, sir.
Okay, there is a lot of other things to discuss, but because of the paucity of time, Dr. Sudesh, you want to tell something in 1 minute, so we shall wind up. So, Sudesh, you have to unmute. Sudesh, you have to unmute.
Oh, sorry, sir. Sorry. There are only two things which I need to highlight, sir. One is with respect to magnesium sulfate, they are supposed to know the therapeutic range and the dosage, the various levels, various kinds of side effects that can be observed at various levels of magnesium, plasma magnesium levels. And second thing is with respect to its use in analgesia as an analgesic. So there is a lot of research going on with respect to its use as analgesic. So that one also you have to remember. And with respect to sodium bicarbonate, one of the most common questions they asked is what are the kinds of preparations available and what is the how many milliequivalents per ml? What is the dose? What is the concentration of sodium bicarbonate? What are the different strengths of that one that is available? Is like one ampule contains how many milliequivalents per ml? That kind of questions are commonly asked. Okay, that's it.
Okay,
Sir.
okay. There are as I said earlier, there are lots and lots of drugs which there is, because of this paucity of time we can't discuss. We just have taken some drugs as samples, and there is a very important master classes next coming up by Dr. Jiggy about ABG and other topics. So we don't want to encroach on their time. Thank you very much, Dr. Sudhish Kannan, for actively participating and contributing for this PGXL 2021. I, being the scientific chairman, I also thank you for contributing for the success of this PGXL. The major part of which is going to start from tomorrow. Thank you. Thanks a lot. And thank you very much all the participants who have prepared well and actively contributed, because if you actively contribute and participate without wasting time, that will be a big success. Thank you very much. Thanks to all the participants. Over to host.
Sir and Sudhish sir, there was one question in between.
Yes.
Akash has asked, what are the coma, sleeping, and lethal dose of thiopentone?
Yeah, I was about to type the answer for that, but in between so many other questions came, so I just missed out on that. Actually, sleep dose, there is nothing like sleep dose is 50% of the induction dose of thiopentone. That is how they do. Actually, this is called graded induction, where you give 50% first and see if the patient goes to sleep, and then gradually go on giving 25 mg increments till the there is loss of high rash reflex. So that is the method of administration of thiopentone. And the next dose, anything more than 10 mg per kg is known to cause coma. And for cerebral protection, the dose can vary anywhere between 25 to 45 mg per kg. This is given in Miller. Some of the old Miller's books, all these details have been given. So you can refer to older Miller books. You will get the dosage for all the sleep dose is 50% of the.
Any other questions? Maybe we can answer in the WhatsApp group. Okay. Yeah, I think we can wind up, Dr. Murali. We shall not encroach on the next.
Yeah, it's already for 6 minutes into
yes.
Sir, and thank you.
Thank you very much. Okay.
Can we exit?
Yes, please.
Next, we move on to our next topic of today's masterclass, that is ABG by Dr. J.V. Divatia and Dr. Trivikram Tantri.
I welcome Dr. Divatia sir and Dr. Trivikram Tantri, and I request them to conduct the session.
Thank you. Are you hearing?
Yes, sir. We can hear you, Trivikram sir.
Divatia sir, I think at join. We'll wait for him.
Hello, sir. Can you hear me? Hello. Good evening, sir. Can you hear me?
Yes, sir.
Okay. So,
yes,
sorry, I'm still driving stuck in Bombay
Dr.
traffic.
Tantri, I can hear.
Hello. Can you hear me, sir?
Yes, sir. Yes, sir. We can hear you. Divatya, sir. We can hear you.
Okay. So good evening. I'm still stuck in traffic. I'm going to speak from my mobile phone. Is that okay?
Yes, sir. No
Sir,
problem.
we can hear.
Okay. So all our students have joined.
Yes, sir. Yes.
Hello. Next class is ABG by Dr. J.V. Divatya and Dr. Trivikram Tantri. Dr. J.V. Divatya is a professor and head of the Department of Anesthesia, Critical Care and Pain in Tata Memorial Hospital, Mumbai. He has special interest in airway and critical care. He is the past editor-in-chief of IJA, past president of All India Difficult Airway Association, past president of Indian Society of Critical Care Medicine. Dr. Trivikram Tantri.
Yeah, I can hear. I can hear, madam. Madam, can you hear?
Yes, sir.
Yes, sir.
Yes, sir. We can hear you, sir.
Okay.
A professor in AJ Institute of Medical Science. Sir has many publications in international and national journals. Over to you, sir.
Yeah. Good evening, sir. Dr. Tantri.
Good evening, sir. Sir, we can hear.
Yeah.
It is not clear. Yeah,
The problem is I'm driving.
Yes, sir.
Do you have the presentation? So do you, that presentation that I sent you, can you share it? Hello?
Sir, actually, I'm sharing the screen.
Yeah.
Yes. You're getting no, sir?
It's still not come. Is everyone else seeing the screen? The slides?
Yeah, we are seeing, sir.
Yes,
sir. First slide we are seeing, sir.
Okay. So I can't see it still on my screen. Okay, so I think what we'll do is, so when we are talking, we are going to focus this on acid-base analysis, right? So when you do a arterial blood gas analysis, you do it for two reasons, right? One is for the acid-base status of the blood, and the second is for the oxygenation and ventilation status. I think we decided, Dr. Tantri and I, that oxygenation is quite straightforward. The main problem that most students have is with the acid-base status. So we will be focusing on the acid-base status of blood. Okay, is that okay? Now, so which slide is showing? It is the measured values and the
what are measured and what are calculated.
yes. So whenever you have that blood gas, when you have a blood gas machine, or when you have a blood gas report, what we need to keep in mind that the blood gas analyzer, the electrodes in the machine, they measure only which parameters? They measure the PaO2, they measure the PaCO2, and they measure the pH. So these are the three electrodes which are there on the machine. All the other values that you see are actually calculated values, right? Including the bicarbonate. So the bicarbonate is calculated from equations. And so what you need to make sure is that the only measured values are these three. Okay. Now,
Sir, you're getting the slides, sir? No?
No, I'm not. So I'm going to just.
Okay.
Okay. So. Okay. So we'll go to the next slide. So I said there are two indications. One is interpretation of acid base, and that is ventilation and oxygenation, right?
Yes,
Now, when you see a blood gas report, you go to the next slide. So I've got this blood gas picture here, right? pH 7.3, CO2 60, and bicarbonate 30. Now, what you need to ask, is this a valid report? Now, with the modern analyzers, it's not such a big problem because they keep self-calibrating and they have QCs and going on. But with the old analyzers, it used to be sometimes a problem, right? So what you have to do is use the Henderson-Hasselbalch equation. So now, for the sake of time, we'll just say that, so if you rearrange that equation, then you get that the hydrogen ion concentration, right, is equal to 24 into CO2 upon HCO3, right? Now, in our blood gas, we don't have the hydrogen ion concentration, right? So what is the pH? What does the pH actually mean? Anyone can say quickly? What is the pH? When you say pH, what are we talking about?
H plus.
Anyone?
I think participant. What are the participants? Yes. Yeah, Sanjana. Okay, Sanjana, please.
It's the negative logarithm of hydrogen ions is pH.
Right. So we know the negative log, but we don't know what is the hydrogen ion concentration. So we have to convert the pH into the hydrogen ion concentration. Now you can, the simple way to sort of do this is, if you see the last two digits of your pH, right? So if you deduct 80, the last two digits of your pH, so if it's normal pH is 7.40, so that's 40 are the last two digits. So if you deduct 40 from 80, then the last two digits, then the difference gives you the hydrogen ion concentration. So for a normal person who's got a pH of 7.40, so you deduct 40 from 80 and 40, that means 40. So 40 is your hydrogen ion concentration. Did you get that?
Yes, sir.
Yeah, so between a range of pH between 7.20 and 7.50, you just deduct the last two numbers of the pH from 80 and you will get the hydrogen ion concentration, right? So this patient's hydrogen ion concentration is how much? 80 minus 30, so 50 is his hydrogen ion concentration, right? So you rearrange the numbers and you will find that, this is a valid report. So we'll not go over this too much, but this is one way of checking that your numbers are reasonably accurate and there's no error in measurement or anything like that, right? Okay, now when you analyze a blood gas report, like you do an ECG, you've got you look at the standardization, rhythm, rate, P wave, QR, PR interval, so on. So here also you should analyze every blood gas report very systematically. And these are 7 steps. So one is there acidemia or alkalemia? So some examiners like to ask this question: what is the difference between acidemia and acidosis? Anyone? Quick answer. Quick answer, anyone? So acidemia is the presence of acid in the blood. So anything to do with the blood is an emia. So if there is a low pH, we call it an acidemia. Okay. So acidosis is the process which causes acidemia. So you can have an acidosis due to various reasons. So any of those processes which lead to acidemia, we call as acidosis. So acidemia is this condition of the blood. Acidosis is the process which leads to that condition of blood. Is that clear? It's not a very big difference, but some examiners like to ask you that. Okay. So 7 steps. First is acidosis or alkalosis. Second is the primary disturbance, respiratory or alkalotic. So I think we'll just go over this. You've all seen the slide, right? So just remember the 7 steps. We'll go over each of the 7 steps in detail. All right. Shall we go ahead, Dr. Tantri?
Yes, yes, sir. Yeah, yes, sir.
Okay.
Yes.
So, okay. Now remember, when you look at a blood gas report,
You can hear.
yeah. When you analyze a blood gas report, there are ranges of normal, right? In the patient, in the physiological ranges are there. But when you're looking at a blood gas report, we take only one value, which is normal. So for that, the normal pH is 7.40. The normal PCO2 is 40, and the normal bicarbonate is 24. And the way we are going to explain the blood gas analysis by using only these 3 parameters: pH, PCO2, and the bicarbonate. All right. Okay. So here I've got 7.40. Any pH which is less than 7.40 is acidotic. Anything which is more than 7.40 is alkalotic. Okay. So now I've got a pH of 7.3, CO2 of 60, and bicarbonate of 30. So what is the first step? Is this acidosis or alkalosis? Anyone?
Acidosis.
Okay. Acidosis. Right. So this is acidosis. Now you need to see whether there is respiratory acidosis and what is the metabolic. So is there respiratory acidosis or metabolic acidosis or alkalosis? All right. So that is the second step. So for this second step,
I think sir got disconnected. Yeah, sir got disconnected, I think. Can you hear me? I'm Dr. Tantri here. Huh?
Yes,
Sir. Yes, sir. Yes, sir.
Yeah.
Sorry. So good.
Yeah.
So so the pH, anything less than 7.40. So first you look at the CO2. If the CO2 is less than 40, it is respiratory alkalosis. If the PCO2 is more than 40, it is respiratory acidosis. So the CO2 tells you about the respiratory component. Okay, and then you look at the bicarbonate. The normal bicarbonate is 24. So any bicarbonate more than 24 is metabolic alkalosis. So the bicarbonate tells you the metabolic component. Bicarbonate more than 24 is metabolic alkalosis, and bicarbonate less than 24 is metabolic acidosis, right? So now in this patient with the PCO2 of 60 and a bicarbonate of 30, what abnormalities does this patient have?
Respiratory
acidosis.
And what else does he have? Is it only a respiratory acidosis?
Compensation is compensatory metabolic alkalosis.
No. Let's not talk about compensation. So he's got a respiratory acidosis and a metabolic
Alkalosis,
right? Because his bicarbonate is less than, is more than 24, isn't it? So this patient has got a, can we just move the slide ahead? Yeah, so he's got a respiratory acidosis and a metabolic alkalosis. In other words, there are two disturbances, right? respiratory acidosis and a metabolic alkalosis. Now, whenever you've got two disturbances, you will always have two disturbances, because when there is a disturbance in one parameter, the body tries to compensate by moving the other parameter in the opposite direction. In other words, if there is a respiratory acidosis, the body will try and compensate for that acidosis by creating a metabolic alkalosis, right? Or the other way around. Is that clear? Yeah. So what we have to decide is of these two. So there are two disorders, right? A respiratory acidosis and a metabolic alkalosis. You have to decide which is the main disturbance or which is the primary disturbance. Okay? And the correct answer is that that disturbance which produces a change in the same direction as the pH. So for example, in this, when I've highlighted the circles, so the pH is, for example, if the pH is acidotic and there is a respiratory acidosis and a metabolic alkalosis, which component is producing? In this example, what?
Sir, I think the audio is a bit disturbed.
We are not able to hear you.
Sir, can you hear me, sir? Sir, can you hear?
Yes, sir. Yes. Yes.
I think there is a. Yeah. I think sir got a little disturbance while presentation. I think let us wait for a minute. Dr. Murli?
Yes, sir.
Sir is there in line?
No, sir. I think he got disconnected. You can
got
continue.
disconnected, I think. I think sir will join, I think. Just see. I'll wait for a minute, otherwise I'll continue. Okay. So now the compensation was, yeah, just try to contact sir, actually. Now here show his slides actually for the compensation. How does the compensation happens? So if you diagnose the respiratory disorder as a primary one, so for example with the high PCO2, carbon dioxide, then the compensation always happens with the metabolic component. So the what is likely to happen is with the high bicarbonate. Now how does this increase in the bicarb happens? It's always debatable. Some say it is because of the renal compensation, or some in textbook of Miller, if you see, it is basically the carbon dioxide exists in the four forms, that is like a dissolved carbon dioxide in the HCO3 minus or carbonated ions and other forms. So our last form is a bicarb. So whenever there is an increase in the PSCO2, there is always likely there is an increase in the bicarb. So what we observe as a compensation, whatever is the irrespective of mechanism which happens, there is a metabolic compensation. Okay. Similarly, other acidotic process also, will continue. That is metabolic acidosis. Whenever there is a low bicarbonate in any patient, for example, sepsis who is hyperventilation. The hyperventilation is because of the respiratory component. That's a carbon dioxide washout. So that's a low CO2 will follow. For other two also, it is a similar ways. Respiratory alkalosis and metabolic alkalosis will end up in high and low carbon dioxide respectively. Okay. Did sir join or shall I continue? I think did sir join?
Illa sir, not yet.
Illa, okay, we'll continue. Okay. So next step is we are likely to, or we are supposed to see for the whether the changes which happened is an acute one or a chronic one. Now, to diagnose acute one, of course, the history is very important, and you see the change of the or the magnitude of change which happened is important. So now this usually we see by the other formulas which we depend on, whether the changes is significant or complete change upon, slow change upon. So for example, in the table of compensation list, if you see, you will see that any change which happened with the carbon dioxide, you will see the pH change of 0.1 for the 10 units change in the PCO2. So the bicarb also similarly, 1 milliequivalent of bicarb for every change in the 10 millimeter of PCO2 will happen. For example, now if at all the PCO2 has fallen from 10 to, from 40 to 30, there is a 1 unit change of bicarb. So similarly, for the respiratory disturbance also. So just try to contact Dr. Divasya, because I think he wanted to present this actually, the compensations. So I'm not sure, should I continue or not? Can you please contact Dr. Murli?
Pardon, sir?
Hello, can you please contact Dr. Divasya once? Should I continue or?
Contacted, he will join. He asked.
Okay. So for the complete tables of compensation, I think I'll take time more than, and it may be more than necessary. I think one can use the Winter's formulas and other tables for the compensation. Now, this is one easy way of remembering for each alkalosis or acidosis, the compensations for acute disturbance and chronic disturbances for metabolic and respiratory acidosis. Usually it goes by 1,4 and 2,4, or sometimes it is given as a 5 here. For respiratory acidosis, you see the change in the bicarb for every 10 increase in the PSU2, the amount of the change which happens is 1 unit or 1 milliequivalent. Okay. So similarly, for other three processes also it is the same thing, 1,4 or 2,5 you can remember. For exam going, it may be mnemonic, easy to remember the changes which happen. Now, after you see how much changes, after you calculate how much changes which happens for the respiratory or metabolic component, now change of one, what is given is rule of thumb, the change of 1 millimeter of mercury PSCO2 for each change of 1 milliequivalent of bicarb. That means to say that the change of PCO2 from 40 to 39, when it becomes, there is a change of bicarb of 1 unit, that is 1 milliequivalent. So the exact calculation goes by the Winter's formula. So not only Winter's formula is useful, other formulas also exist actually to refer. So that's why any formula is fine to calculate the expected change. What is required to remember is expected change, whether that happens is happened in your ABG. Did it whether it is observed in your ABG is important. Suppose if it has not happened, that means either complete compensation is not there, or a mixed condition can coexist, or mixed disorder can be identified. That's why these formulas are important. So we are not going to in detail about the formulas. Let us go to solve some of the problem. Now, we can see here a metabolic event. What is the expected PSO2, the winter formula. So it should be multiplied by 1.5 and added with the 8 units for calculation of the PSO2. Now we will see in this example. So for example, pH is 7.3 and this patient has got a PCO2 of 35 and a bicarb of 18. Now what is our expected PSO2? How it is calculated? Can anybody answer this? How it is calculated? The patient of pH of 3 and PCO2 of 35 and bicarb of 18. What is the expected PCO2 in this? Are you hearing?
Yes, sir. Yes, sir. No problem.
Yeah. Now, what is the expected PaCO2 for this patient? Now, if you apply the formula, Winter's formula, now 1.5 is the standard coefficient which you multiply with the bicarb. Now add with the 18. So what you get is 35. That means expected PCO2 for this patient is 35. Now in this, actually this ABG is a patient of metabolic acidosis. The bicarb has fallen. Okay, the respiratory normally PCO2 we take as 40. From 40 it has fallen to 35. Now when it falls to 35, so the 5 change has happened. Now to confirm that the compensation is adequate or not, from 40 when it has fallen to 35, now it should be done through the Winter's formula. Now once you calculate this as a 35, see we can see the 35, the calculated value of PCO2 also is 35. So what we expect is compensation has happened as we expect. So that means in a patient with metabolic disorder, when the patient hyperventilates, so we can definitely calculate this. In case if the PCO2 is either high or if it is lower or lower than the expected value or the calculated value, so what we say is there is another problem in the patient. For example, if it is 40, then with the bicarb of 18, PCO2 of 40, that says that there is a component of respiratory illness which has caused, otherwise it should have been 35. But actually in the ABG we are getting 40. So that means there is another component of respiratory illness. Similarly, opposite way, if it is 30, so the compensation is more than expected. There is another component, probably respiratory alkalosis is happening, or the PCO2 washout has happened. That's why the compensatory formulas are important. So let us calculate also in the future, some of the formulas are there. Okay. Suppose if that's what I told, if the compensation is as per the calculation, then we name that as a single or a primary acid-base disorder. If the compensation is less than or greater than the calculated values, expected values, then there is a dual or multiple acid-base disorder exists. So that is why these formulas are used. Okay. So, sir. Can you hear, sir? Yeah. Now, can anybody comment on this case one? Students are there, no? Can anybody? Yes, sir. Can you explain this? Now, this patient is at the pH of 7.23 and PCO2 of 25, and there is a bicarbonate of 12 and the sodium of 1.5, potassium of 4.8, and the chloride of 99. Now, can this stepwise approach with using 7-step approach, can anybody comment on this? I think important need to answer this question. 7-step approach, you have to utilize this.
Good evening, sir. I've joined back.
Yes, sir.
Thank you. Thank you for
Sorry, I
carrying.
continued, sir.
Yeah, yeah.
Two slides here.
I know. I saw.
Compensation and huh?
Yeah.
Okay.
Yeah. Thank you.
Yes. I was a bit fast actually. I thought
But
we
we'll
are
take
running
time.
short of some time for the solving the problem. Yes, yes, sir.
Okay. Next.
Sir, you go ahead, sir.
You'll have to change
Case
because
1 we are in, sir.
yeah.
Yes, sir. I'll change.
Yeah.
Case 1 we are in.
Yeah. So I can see. So now, so this is acidemia, right? Because the pH is 7.23.
Yes.
What is the next step?
Primary disturbance.
So no. Next step. What is the next step? First is acidosis. Then is it respiratory? What are the components? Respiratory or metabolic?
Respiratory or metabolic.
So what is the respiratory component? Respiratory is showing what? Akash, respiratory?
Respiratory alkalosis.
Metabolic?
Metabolic acidosis.
Which is the primary component therefore?
Metabolic acidosis.
Because it is in the same direction as the
pH.
Okay, next slide, sir. Just move the slide.
Yes.
Yes, the primary is metabolic. Okay. So now if it's metabolic, then the compensation has to be done by the CO2, right? The respiratory component. How do you calculate the respiratory component? So what is the expected CO2?
The expected, as per the formula, it should be around 26 plus minus 2. So that falls within the range. It's 25.
Yeah.
So the compensation is there then.
The compensation is as predicted. That means this is a compensated metabolic
acidosis.
So I just want to highlight one more time that compensation doesn't mean the pH is normal. Compensation means the compensating component tries to restore the pH towards normal, but not actually normal. Sanjana, I wanted to ask a question.
No, sir. No, sir.
Okay, you had your hand up. Okay. Okay. So now you've decided that this is a metabolic acidosis, right? So what is the next step for doing a metabolic acidosis?
Is the compensation okay? So compensation is okay. If anion gap is present.
Right. So if there's a metabolic acidosis, always look at the anion gap. Okay, good. Next. What is the next step? So what is the anion gap? Next slide, sir.
Yes, sir.
So the anion gap is sodium minus chloride plus bicarbonate. Okay, so we are not taking the potassium into account. We are just taking the chloride and the bicarbonate, and that should be normally less than 12. If the anion gap is more than 12, we call it as a wide anion gap or an anion gap acidosis, and that is because of unmeasured anions, right, such as sulfates, phosphates, lactates, and so on. And the common causes of metabolic acidosis with a wide anion gap is given by this mnemonic mud piles, right? Someone can tell us what mud piles is? M is methanol, uremia, diabetic ketoacidosis. P is what?
Formaldehyde.
Formaldehyde. I is? Sorry? I is? Infection, lactate, ethylene glycol, salicylates. Okay, roughly. So you can get these sort of causes of wide anion gap acidosis. If it is less than 12, it is what we call as a non-ion gap acidosis or non-gap acidosis. And usually it is because of loss of bicarbonate or a hyperchloremic acidosis. So we'll come to that. Okay. Now, a very important step you must always do is adjust the normal anion gap for the serum albumin. Okay. So, for example, if the anion gap is say 15, but the albumin is 2. So you take the albumin, normal albumin is 4. So every fall in albumin of 1 below 4, you add 2.5 to the anion gap. So if your albumin is 2, that means the albumin has fallen by 2. So you need to add 5 to the anion gap. So the anion gap is not 15, it is actually 20. Is that understood? Is that concept clear? So always correct the anion gap for the albumin level. And that brings you actually very close to solving many, many problems, which you may have missed out if you don't adjust the anion gap for the serum albumin. All right. Okay, next. Okay. So once you've got the anion gap and you decided it's a wide anion gap acidosis, right? Remember, when the anion gap is wide, it means you have added acid, right? It's because of addition of acid. So theoretically, whatever amount of acid is added should reflect the fall in bicarbonate. In other words, the change in anion gap should equal the change in bicarbonate. Is that understood? Generally, is that clear? Yes or no? Someone?
Yes, sir.
Yeah. So now, and so if you say that the bicarbonate, so change in bicarbonate, that is 24 minus bicarbonate should equal anion gap minus 12. If you rearrange that, then you get the bicarbonate, you get this formula, right? Bicarbonate plus anion gap minus 12 should be equal to 24. If it is more, it means there's an additional metabolic alkalosis, an additional one. On top of your metabolic acidosis, there could be a metabolic alkalosis. And if it is less than 24, it's a hidden non-anion gap metabolic acidosis. Now, these two things are extra information. In your exam, I think if I was your examiner, if you're just able to get to anion gap and tell me whether it's a wide anion gap or a non-anion gap, I would be happy. If you want to score a gold medal, you should be able to answer these two questions. Okay. So shall we move on? Next slide.
Yes.
Okay. So just like, so this is called a gap, right? It's called a delta gap. So what I just told you, if you want to call it more formally in some books, it will be called as a delta gap. And it is nothing but the change in bicarbonate should equal the change in anion gap. So delta HCO3, so 24 minus the bicarbonate, that is a delta bicarbonate, should equal the delta anion gap, that is anion gap minus 12. Okay. So same thing, if the anion gap, if the change in bicarbonate is less than the change in an anion gap, it means there's an additional metabolic alkalosis. So if the anion gap, say, had changed by 20, right? So that means ideally the bicarbonate should also have gone down by 20. But if the bicarbonate has gone down only by 12, that means there was an additional metabolic alkalosis, which was causing some more bicarbonates to remain over there. And the other way around, if the bicarbonate, change in bicarbonate is more than, so the fall in bicarbonate is more than the fall in the anion gap, that means there is an additional metabolic acidosis. Okay. But these are gold medal questions, so we'll move on. So just to give you an example, so this is a patient who's got diabetes mellitus. His anion gap is 23 and the bicarbonate is 18. So how much is the change in anion gap? How much is the change in anion gap? 23 minus 12. So the change in anion gap is 11. The delta anion gap is 11. But the bicarbonate is gone down from 24 to 18. So the change in bicarbonate is only 6, right? So in other words, the bicarbonate should have fallen by 11, but it has fallen only by 6. That means what? What does that mean? There is an additional
metabolic alkalosis.
Yes, there is more bicarbonate than expected. So there is an additional metabolic alkalosis. And then you can, next slide, sir. So then you can figure out as to why do you think this patient might be having a metabolic alkalosis. Someone may have given a bit of bicarb, we don't know, right? But there is an additional metabolic alkalosis in this patient. Another example, there's an alcoholic with a history of diarrhea, right? And he has an anion gap of 17 and a bicarbonate of 10 with a metabolic acidosis. So now the anion gap has changed from 12 to 17. That means the anion gap is 5. The anion gap has changed by 5. But the bicarbonate has gone down from 24 to 10. So the bicarbonate has gone down by 14. So although the anion gap has changed by 5, the bicarbonate has fallen even more. It's fallen by 14. That means there is an additional metabolic acidosis. Yes. And why do you think this patient might have an additional metabolic acidosis? This could be because this patient has diarrhea. The clue is in the diarrhea. In the diarrhea, the patient loses bicarbonate, and that is causing an additional non-anion gap acidosis. Is that clear? Okay.
Yes.
So whenever there's a metabolic acidosis, you first ask, is there an anion gap? And then if you want a gold medal, you ask, does the change in anion gap equal the change in bicarbonate? All right. Okay. Next. Okay, so just like you've got a delta gap, you've got a delta ratio, which is nothing but the ratio of the increase in anion gap to the decrease in bicarbonate. Okay, and if it should usually be, it should be 1, right? If it is much more than 2, it means there's an additional metabolic alkalosis, right? And if it's less than 1, it suggests an additional metabolic acidosis, often due to renal failure. Okay, we'll go on to the next one. Okay, now we have to start solving these cases, right? Okay. So this is, so we've done all this. Next. Next, sir.
Next slide, sir.
The next. Okay, so in this, we concluded there was a metabolic acidosis, right? So now what was the anion gap in this patient? It was 135 minus 12 plus 99, right? That's 111. So the anion gap is 24. That is much more than 12, right? So this is a wide anion gap acidosis. So this patient has got a wide anion gap acidosis. What is the next step that you have to ask? Anyone? Shabnam, Mansi, and Akshat were answering so far. Anyone else?
Whether the change in bicarb is equal to the change in the anion gap.
Wonderful. So what is it equal to, or is it not equal to? But before that, is this anion gap correct? Ideally, you should be checking the albumin level, but we are going to assume the albumin is normal. Okay. So is the change in anion gap equal to the change in bicarbonate? Anion gap has changed by 12. Bicarbonate has also changed by
12.
12.
Yes,
So the change in anion gap
is equal to change in bicarbonate.
Bicarbonate. So therefore, there is no additional component over here. So the next slide, sir. This is a pure metabolic acidosis with no additional component. Next, we can also calculate the delta ratio, and this is 1. So again, this tells you there's a wide anion gap acidosis, and with this history, this patient probably has a diabetic ketoacidosis. Okay. All right.
Yes, sir.
Okay. You can also look at a urine anion gap. We won't go into great detail about urine anion gap, but it's just like you've got a plasma anion gap. You've got this is urine sodium plus potassium minus chloride, and the principle behind this is that the chloride reflects the ammonium excretion, which takes care of excessive acids secretion in the urine, right? So this is more than a gold medal level question for us. So we will just leave it and go on to the next sort of. Okay, next. It's basically used to diagnose renal tubular acidosis. So we'll just move on to the next slide. Okay, so now this is a patient with several days of severe diarrhea. Okay, so this is the pH. Bicarbonate is 12 and the CO2 is 36. So can someone start analyzing this gas?
Acidosis.
Acidosis. Metabolic acidosis.
Metabolic acidosis.
Respiratory.
This formula. So,
alkalosis, right? Respiratory alkalosis, right? Using Winter's formula, what should be the CO2?
Around 24 to 28, but this is 36. So it's
that means there is a
higher than precipitated,
higher than expected CO2. So in other words, there is an additional respiratory
acidosis component.
And then again, you need to figure out clinically why this may be happening. Maybe someone has given this patient a sedative, or maybe he's just so weak and tired that he's not breathing. We don't know. But there is an additional respiratory acidosis. Okay. Now, we've not given you the sodium and levels over here, or the chloride levels. But what sort of acidosis would you expect in a patient with several days of severe diarrhea? Wide anion gap or a non-anion gap?
Non-anion gap.
It would expect a non-anion gap acidosis because of loss of bicarbonate. Okay, next slide, sir. Okay, this is a child with status asthmaticus. Started several hours ago. So just go back one. Just go back.
Yes. Case 3, sir. No, sir. Case 4, no?
What do you think this is?
Status asthmaticus, no, sir?
Yeah, it's status asthmaticus, and it started a few hours ago. So I've started sharing my screen. So I think
yes, yes.
So, what do you think is the disorder? The pH is 7.20. Carbon 26. What do you think this is? CO2 65.
Respiratory
acidosis.
Okay. Then
with normal bicarbonate.
Bicarbonate is not, sorry, bicarbonate is not normal. I said 24 is normal, right?
Yes, sir.
So this is metabolic
Alkalosis.
alkalosis, respiratory acidosis, right?
Acidosis. Yes, sir.
Which is the primary component?
Respiratory acidosis.
Is this respiratory acidosis acute or chronic? That's the next question, right? Whenever there's a respiratory problem, you have to ask whether it's acute or chronic. So is this acute or chronic?
Acute.
Why do you say
Acute,
it's
sir.
acute?
Because the history suggests that it started several hours ago.
Okay, very good. So one is the history. From the pH and the CO2, can you make the determination? CO2 has gone up by 65, right? So it's gone up by 25.
25.
For in an acute respiratory acidosis, each 10 change in CO2 should produce a 0.1 change in pH. So your pH should be
around 7.2 because it's increased by around 20.
So if the CO2 has gone up by 25, the CO2 should have gone down by 0.25, right? So it should have been 7.15. Okay. So it's a little short of a very acute problem, right? And maybe because it's several hours, so maybe some compensation has started creeping in. But this is by and large, we're pretty close to the value you would expect. So this is a acute respiratory acidosis, right? So how much should the pH change be in acute respiratory acidosis? How much should the bicarbonate change be? Next. So how much should the change be? For every 10 change in CO2, how much should the bicarbonate change? For every 10 change, it should change by 1, right?
1.
So this has gone up by 25. So the bicarbonate changed by about 2.5. So 26.5. So it's pretty close to what we have, right? Have you got this part clearly? For an acute change in for an acute respiratory acidosis, the bicarbonate changes by 1 for every 10 change in CO2. Someone's raised a hand. Who has raised a hand? Dr. Mukta Mansa. Yeah, Mukta, what is your question?
Sorry, sir. I do not have any doubts, sir. I just wanted to answer.
Okay.
I wanted to participate.
Okay, you take the next question then. Okay. Okay. So this is a 45-year-old male with acute intestinal obstruction of 3 days and oliguria. This is picture. 7.20, 25, bicarbonate 10, sodium 131, chlorides 98.3. So yeah, Mukha, you want to participate? Please start. Is this?
Yes, sir. It is acidemia.
Metabolic or
metabolic, sir.
Primary metabolic, right?
Primary metabolic acidosis.
Excellent. Now, when the primary is metabolic, what is the next step?
Compensated.
Respiratory compensation we need to check.
How much is it? Is it adequate or not adequate? So for a bicarbonate of 10, what should be the PCO2, right?
Yes, sir.
Please calculate quickly and tell me.
It's It partial, looks like partial.
21 to 20.
So it comes to 23 plus
25.
minus 2. So
Compensate.
we are there, right? 25. So there
Yes,
is
sir,
no
compensated.
respiratory cone. There is a compensated metabolic acidosis. Once you get out of this thing, metabolic acidosis, next step is to see the
Anion gap.
which is 23 almost, right? 22.7. So there's a high anion gap.
High Hagma. Yes, sir.
Next, once you know this is a high anion gap acidosis, what is the next step you should see? Does the change in
Change correlate with the anion gap?
Anion gap
To
equal
see
the
if
change
there's
in,
any mixed disorders.
yeah. Does the change in anion gap equal the change in
Equal to the change in the bicarbonate.
How is the change in anion gap? About
still 10 almost.
About 11, right? 23, 22.7
Yes,
is
yes.
23. So 11 is the change in anion gap, and the bicarbonate has gone from 24 to
24 to
10.
10.
Right?
14.
Anion gap has changed by 11, but the bicarbonate has gone down even more. It has gone down by 14.
3 more. Yes.
That means there is an additional
Hidden metabolic acidosis somewhere.
additional metabolic acidosis. Excellent. Okay, so consider a hidden non-anion gap metabolic acidosis. Correct? You got it without my showing you the slide. Excellent. Now you can also do a delta ratio, right? And which comes to less than 1. And a delta ratio less than 1 suggests that this is due to
Non-gap.
Kidney problems.
renal
Non-gap.
dysfunction, right? And this again fits in with your nice clinical picture. This is a patient who's got intestinal obstruction, oliguria, several days of obstruction. So he's probably got fluid losses into the gut and so on. And therefore he's got pre-renal failure, and therefore he's displaying this blood gas report. Is that right? Okay, so always try to fit your gas into your clinical picture as well. Okay. Are we okay with this gas?
Yes,
Dr.
sir.
Patri, is this okay?
Yes, sir.
Okay. So high gap acidosis due to renal failure. Okay. Who's going to take this case? Okay. 75-year-old man. Amruta. Amruta, you want to do this case? Please put on your video. Amruta. 75-year-old man, known case of congestive heart failure on diuretics, presents disoriented, and this is blood gas picture. Okay, pH is 7.55.
Hi, sir.
Peak CO2 is 48.
48.
Bicarbs are 36. Sodium, potassium, and chloride. Okay. Okay, Amruta, start.
Sir, pH is alkalotic, sir.
Excellent.
So the change is bicarbonate is rise, sir. So it is
Yes.
metabolic alkalosis.
So primary metabolic
Alkalosis.
alkalosis. So when you've got a metabolic alkalosis, what should be the CO2 should be high, isn't it?
Yes, sir. For every 1 milli equivalent rise in, for every 10 for every 1 milli equivalent rise in HCO3, PCO2 should decrease by 10, sir.
Should increase or decrease?
Should increase.
Increase. So, or you can also use Winter's formula, isn't it?
Yes, sir.
Yeah. So if you put what is the formula? Winter's formula for alkalosis?
So HCO3
Okay. So
is
0.7 into the bicarbonate
0.7 plus 20.
plus 21 plus or minus 1.5. Okay. So when we put these numbers in, this patient turns out the expected CO2 is 48, which is exactly what is we are seeing. So this is a
No compensation.
this is adequately compensated
compensated metabolic alkalosis.
because the PCO2 is as predicted for the bicarbonate. So it is a compensated metabolic alkalosis. Right? There's no additional respiratory component. There's a metabolic alkalosis. Here, should we calculate anion gap?
No, sir.
No, only for an acidosis, metabolic acidosis, right?
Yes.
Now the question is, why does this patient have a metabolic alkalosis? So the clue is in the history. This patient was getting
Diuretics.
a diuretic. Okay, Sanjana, what else is there which can promote a metabolic alkalosis in this patient? I think you have to wind up in a couple of minutes. Sanjana, you put up your hand. So, okay, so things which, there are two things in his blood gas picture, in his electrolyte picture, which tell you why this patient is having an alkalosis. One is a hypokalemia and a hypochloremia. So there is probably hypovolemia because of diuretics, which initiates the alkalosis, and it's maintained by these two things, which is a low potassium and a low chloride. And alkalosis is sort of classified as saline responsive and saline resistant. So a patient with hypovolemia and hypochloremia will respond very well to normal saline, and many alkaloses will respond well to normal saline, right? Of course, you have to be careful because he's got congestive heart failure, but you need to give this patient chloride, replaces chloride with normal saline, and you replace his potassium with potassium chloride, right? Some which are chloride resistant have got defects in the renin, angiotensin, aldosterone secretion, and they have so they are really difficult to treat, and they are more endocrine and renal problems that you need to treat. Okay, so that's about metabolic alkalosis. Okay, who wants to take this last case? Anyone?
Yes, sir.
Who's this?
Akash.
Akash. Akash is always. I think let Shruti speak. Shruti,
Yes,
Shruti has raised hand. Shruti, unmute yourself. Put on your video. Okay, please start reading this. 30-year female undergoing hysterectomy. Tidal volume 500, respiratory rate 15, FiO2 0.4, pH 7.52, CO2 30, bicarbonate 23. Yeah, Shruti, please read it. Shruti, can you hear me? Can you unmute yourself? Okay, Akash, carry on.
Yeah, yes, sir. So its pH is 7.5, sir. So it's alkalosis.
Yes.
Next, determining if it's because PaCO2 is 30, so that is going towards lower side. So it's respiratory alkalosis, sir.
Yeah.
And moving on.
Which is the primary component?
Primary component will be respiratory alkalosis, sir, because bicarb has not, I mean, it has come down, so that's why it should be respiratory alkalosis, which is
same direction as pH. Okay.
Same direction as pH, yeah.
So is it acute or chronic?
PCO2
the respiratory component
is 30.1.
Chronic.
So it is coming down by 0.1 for every 10, and I mean going up 7.5. So that is 1. So it has come down by.
No, the PCO2 has come down by how much?
By 4, sir.
PCO2.
10. Carbon dioxide. Come from 40 to 30, no?
Yeah, 40 to 30, yes, sir.
That's 10.
40 to 30. So it's come down by 10. So by 1, if it has increased, it has come down by 10. So it's acute, sir.
Because so for a 10 drop, for a 10 change in CO2, you expect the pH change also to be the same, right?
Yeah, by 0.1.
Right, so it should be 7.5, which it is about 7.5. So this is an acute
case of respiratory alkalosis.
Yeah, right, and you can know that from the history also. It's just undergoing an operation and has been ventilated for an hour or so with this high tidal volume and respiratory rate. So it is an acute respiratory alkalosis. Is there any compensation? Is there a metabolic component? So for a CO2 of 30, what should be a bicarb in acute respiratory acidosis? For every 10 change in CO2,
for every 10, there will be 1 decrease.
1 decrease, right?
Yeah. But it is decreased by 2. So it should be around 23.
Yeah. So maybe there's a little small metabolic component as well, right?
Yes, sir.
Maybe because the patient is hypovolemic or whatever it may be. right?
Yes, sir.
Okay. Okay. So I think we finished for the day. I'm sorry there was a problem with my net connection. So please remember that you must do your blood gases, and when you analyze them, please do them by the 7 steps that we discussed, right? If you do them by the 7 steps and remember some basic rules, you will not go wrong and you will be able to do very well. You will be able to crack your exams, and you'll also be able to analyze blood gases in the OT and in the ICU. Okay. Okay.
Thank you, sir.
Thank you, and sorry, very sorry for the glitches. Dr. Tantri, thank you very much.
Thank you, sir. I am sorry. Actually, I had to go fast. I thought we are running short of time, and I had 3 computers I had to arrange it for the presentation. So I was busy in actually uploading because I had only one internet source, and I'm sorry for that. It was very nice, sir. Actually, I just wanted to add there. Actually, for every case, I think they can look at the pH also by pH changes, also by the change in the pCO2. For example, the 10 millimeter of change in the carbon dioxide and pH changes by 0.08 units or 0.1 units. That becomes a little easier than calculating or using other formulas. Then another one is delta.
Many books will give you different formulae.
Yes,
and different people. But I found these to be the simplest, just because as it is, doctors are mathematically challenged. So 0.1 and 10, rather than 0.08 and 10 and all, it just makes it a little simpler. And it's rough, and it works reasonably well in practice.
No, not about the values, sir. Actually, pH changes, calculation becomes a little easier. Then one more thing is delta ratios less than 1 and more than 2. Is it always a mixed disorder? I think they can remember by the such thing. Delta ratio, if it is less than 1 and more than 2, there will be a mixed component. Yes.
In
One
the
is
setting of
alcohols
white
and
anion gap acidosis,
yes.
metabolic acidosis.
Yes. Yes.
Yeah.
Yes, sir.
Thank you, Divatya sir, and thank you, Tantri sir, for your wonderful
Thank you.
And I appreciate for maintaining that time, and even though after so many glitches, you have finished it on time. So thank you, sirs. Now we will move on to the next session. Next session.
Next session is capnography and chest X-ray by Dr. Namrita Ranganathan and Dr. Prasad CGS.
We start. Can you hear me?
Yes, yes. Prasad sir.
Hello, good evening. Good evening.
Good evening. Good evening.
Yeah.
Dr. Namrita Ranganathan is a professor and head of the Department of Anesthesiology, Pain and Palliative, Fulbright Memorial Institute of Oncology. Madam's special interests are difficult airway, pain and palliative care. Dr. Prasad CGS is a professor and head of the department. His special interests are pediatric anesthesia, physics in anesthesia, and anesthesia machine. Over to you, ma'am.
Good evening, everybody. The last session of masterclass, and I think all of you want, you can actually stretch yourselves. So myself and Dr. Prasad are here to take capnography and X-ray. And we both have done it, like I'll be taking capnography and he'll be doing X-rays, and wherever required we need to contribute, we will contribute. So without taking much of time, I'll just share my screen with you people. Just a sec, please. Are you able to see it?
Yes, ma'am, we can see.
Okay. So who are the students with me? Anybody? Ravali?
Yes, ma'am.
Chalo. Why don't you start? What is capnography?
It's a recording of CO2 concentration against time.
Anybody wants to add to it?
Ma'am?
This capnography, what else it can tell you?
It tells us about the ventilation of the patient, end-tidal carbon dioxide. And it gives us it tells us about the respiration and the circulation as well of the patient, of a patient on ventilator.
Only on ventilator?
Otherwise, if the capnography is connected, the sample line is connected for a conscious patient as well.
Anybody else would like to add it? What all can we get from capnography? So basically, we are doing a continuous monitoring of instantaneous carbon dioxide and respired gases. So here, remember one thing, that we are not even getting, we are getting a pulmonary process where we are getting the elimination of carbon dioxide from lungs. Indirectly, we are getting production of carbon dioxide at tissue level, that is the metabolic process, and delivery of carbon dioxide to the lungs, that is the circulatory process. So that is why all three things we are getting in this. Now, why do you want capnography? Given a choice to you students, if you have a pulse oximeter or capnography, what would you prefer? Kavya, you have raised the hand. Answer. Kavya?
Hello, ma'am. We can go with the capnography, ma'am.
Why?
Because any changes during the intraoperative period, we can make out as early as possible when compared to saturation.
What all you can make out?
Any falling the BP also can be made out by reducing the EtCO2 will be less. And any disconnection of the tube and hypoxia can also be made out.
So both of the pulse oximeter as well as capnography is giving you hypoxia. But what is the advantage of capnography?
Acute detection.
Early detection.
Early detection. Anybody else wants to add something to it? So all of you agree that you would prefer a capnogram than the pulse oximeter because of early detection of hypoxia as compared to the pulse oximeter. So basically it can help us, and remember that along with oxygenation, it gives us information of carbon dioxide production, pulmonary perfusion, alveolar ventilation, respiratory patterns, elimination of carbon dioxide from anesthesia circuits, and ventilation. Now, can anybody tell me something about these terminologies like capnometry, capnometer, capnogram, capnography, capnograph? Anybody? Okay. Ravali, would you like to? I know Yashaswani is there. Yashaswani?
Capnometry is the measurement of the gas, ma'am, and capnometer is the device which measures the gas. Capnogram is the device which gets the graph, and capnography is the graph.
And one is the one which gives in digital form. That is in numbers. When you see a monitor, you will either see the numbers, you will see the waveform. Okay, what is the waveform?
Capnograph.
What is the digital number?
Capnometry.
Yes. Then what are the types of capnogram then? Okay. Anybody else?
It is volume capnogram and time capnogram, ma'am.
Good.
If it is time capnogram, the time and the value of the EtCO2 will be value of the CO2 will be measured. If it is volume capnogram, the volume, tidal volume and the CO2 will be measured, ma'am.
Okay, so we'll come it again. So capnometry, there is a digital or analog monitor where you get the numbers. Capnometer is the device which measures it. Capnograms are the carbon dioxide waveforms, which can be, plotted against the time or the volume. And then capnography is the graphic display, and capnogram machine is which generates the waveform. So remember these, that you can have two types, time and volume capnograms. You have a capnography, which is the graphic display, and capnograph is the machine which generates the waveform. Now, what are the types of capnographs? Like mainstream and side stream. So what would be your choice? Would you prefer a mainstream or would you prefer a side stream capnograph?
Side stream, ma'am.
Why will you prefer side stream, sweetie?
Because, ma'am, it doesn't add weight to the circuit, ma'am. And it doesn't cause burn to the patient.
What else?
We can also use in patient who is spontaneously breathing.
You can use it in?
A patient who is not intubated also. If the patient is on simple face mask or nasal cannula, during that time also we can use.
Who's answering?
This is Yashaswini.
Okay, Yashaswini. So you said you would want a side stream because you want a patient who's spontaneously breathing. You said you only said that burns will not happen?
No. Sweet.
Oh, sweet. So what other things? What is the advantage of mainstream?
Ma'am, it doesn't cause us fogging.
Okay.
It doesn't give
you mean to say water vapor pressure?
Yes,
There
ma'am.
won't be a time lag, no time lag with direct visualization.
Yes, ma'am.
Why there is a time lag in side stream?
Because the 6 feet long connector is there, so there's time, because the analysis, it will take time, man, for the gas to travel to the
Where is this? So mainstream is
atmospheric pressure correction has to be done.
Sorry to interrupt. Where is side stream connected and where is mainstream connected?
Mainstream directly to the circuit and near the patient, and side stream
near the monitor.
Yeah.
Sterilization is issue with what?
Side stream.
Side stream, you can change the sample line.
No, we can't change.
Why you cannot change? How do you keep only one sample line? Or since it will be. So remember that we'll just go just a quick mainstream capnographs. Carbon dioxide sensor is located between the endotracheal tube and breathing circuits. And side stream capnographs, sensor is located in the main unit and carbon dioxide is aspirated via sampling line tube. There's one major difference is that in prone position or different type of position, the mainstream cannot be used. So my preference will be side stream, because in cases like, when different positions are given in thoracic anesthesia or in prone position and all, it's easier to use the side stream than the bulky. Now anyway, even the mainstreams which we are getting disposables are lighter ones. And the chances of burns are also less, and they're less heavy and less traction ones mainstream are also we are getting. And there is no effect or change in water vapor pressure in mainstream, and there is no delay in recording. In side stream, it's easy to correct, no problem with sterilization. It can be used both in awake and non-awake, non-intubated patients, and it is easy to use when patient is in unusual positions and in prone position. Okay, and another important factor is it can be used with simultaneous oxygen administration via nasal tube. Now, what is this? Can anybody identify this? Ravali? Yashaswini, anybody? Akash?
I think the first one, it's it's on ventilator, and the second one is probably in hand bagging initially.
No, so these are actually real-time capnograms or trend time capnograms. This is depending on the speed with which we are recording them. The first one is with the 7 millimeter speed. The second one is by 0.7 millimeters. So the first one will give you the whole breath. So this is basically a carbon dioxide concentration plotted against time at 2 speeds. Real-time capnogram is high-speed recording at 7 millimeter per second, giving detailed information of each breath. Whereas the trend capnogram shows slow speed recording at 0.7 and shows overall change in the carbon dioxide. Anybody fast? Components of a time capnogram? Can anybody tell? First, second, third? 0 first, second, third? Anybody? Ravali?
First is the end of inspiration, ma'am. Second is during the dead space non-gaseous exchange phase of expiration, and three is alveolar expiration, and 4 is a sudden drop during the inspiration again. This alpha angle usually there is a slope, and it usually is 100 to 110, and beta will be 90 degrees.
Anybody else wants to add anything? So we'll go a little faster. So basically just whatever she said, phase 1 anatomical dead space, phase 2 is mixture of anatomical and alveolar dead space, phase 3 is alveolar plateau, and phase 0 is inspiration. Okay. Now, what are the advantages of time capnogram? It is simple and convenient, monitors non-intubated patients and monitors dynamics of inspiration as well as expiration, but it has a poor estimation of ventricular perfusion mismatch. It cannot be used to estimate, the physiological dead space. So what is the difference between volume capnogram and time capnogram? Can anybody tell me? So basically you don't have a zero phase in it. You don't have a inspiratory phase. No inspiratory segment is there yet in the volume capnogram. And the slope of the phase 3 is a better reflection of the ventilation perfusion status in lung compared to the time capnogram. Okay. Can anybody tell me what are these things? What is PaCO2 and PtCO2? What is normal AET-PCO2 and what is the clinical significance? Akash?
Arterial CO2 is arterial tension of partial pressure of carbon dioxide in the blood is PaCO2. And end tidal carbon dioxide at the end of respiration is PtCO2.
What is the normal difference between the
5 mmHg, ma'am. 5 to 10 mmHg is the difference.
2 to 5. Okay. What is the clinical significance of it? If the gradient is increased? Normally we say it's approximately equal. Yeah. Can anybody answer? Ravali, Yashasvi, Akash, anybody else who are not here?
Increase in bed space.
Yeah. Can you add some more students to it? So basically, it's the difference between arterial and end tidal carbon dioxide. Its difference is about 2 to 5 millimeter, and the gradient is due to ventricular perfusion mismatch. So whenever the gradient is increased, it is because of increase in dead space, like when you have a low cardiac output status, hypovolemia, pulmonary embolism, decrease in carbon dioxide production. So all these can increase the gradient. Now, can anybody tell me a relation between the cardiac output and end tidal carbon dioxide?
Again, VQ mismatch, ma'am.
So if the patient's cardiac output is more, what will be the end tidal carbon dioxide?
Will increase.
And when it is, when you were saying that in the graph only, you can see if there is like, what was the blood pressure, how much is the perfusion, like if it is less end tidal carbon dioxide. So how it relates to carbon dioxide? Like you said, if it is low means? If EtCO2 is low means cardiac output is
less.
It is low.
Less.
So basically reduction in cardiac output and blood flow results in a decrease in
EtCO.
okay, and increase in cardiac output results in better perfusion alveoli and rise in end-tidal carbon dioxide. So they say if any end-tidal carbon dioxide is more than greater than 30 millimeter of mercury, it associates with the cardiac output of about 4 liter per minute. Now, how will you interpret? What are the things you should see when you're looking at a capnogram? What are the 5 things would you like? Are you getting my question?
The
When you're
entitled
reading
carbon dioxide value.
Capnogram. So what all you will see?
The waveform.
Yes.
Then if it's touching the baseline or not.
Very good.
The angles, if there's any change, if there's any notch.
So that is the shape of the capnogram. Then?
And the value should be between 25 to 35, ma'am. 40.
That's a different thing. When you're looking at a capnogram, what would you like to see? When you have the graph, right? So would you like to see what is the rate? What is the rhythm? What is the height? Is it touching the baseline? Okay, so basically 5 things you need to see: frequency, rhythm, height, baseline, and the shape. Okay.
Yes, ma'am.
Now, who will tell me what are this is like a general thing, like when does the end-tidal carbon dioxide increase? Are you getting my question? There are innumerable causes when this will increase.
Ma'am, in case of increased metabolism, ma'am,
Yes.
like if there is
Hypoventilation.
increase
Yes.
in temperature of the patient in case of convulsion, shivering, and increase in cardiac output as a circulatory cause.
So basically we'll divide it into 4. Wait, just remember that one is when there is increase in carbon dioxide output. So in pulmonary perfusion, alveolar ventilation, and technical errors. So as you said, increase in carbon dioxide output level will be whenever metabolism has increased, like fever, malignant hypothermia. Then if some sodium, bicarbonate is given, or tonic is released, or venous carbon dioxide embolism. Now pulmonary perfusion, you said increase cardiac output and increase blood pressure. Now tell me alveolar ventilation. What will happen in to alveolar ventilation, which will cause increase in end-tidal carbon dioxide?
Hypoventilation.
Yes.
Any airway obstruction.
Very good.
Rebreathing.
Yes. Okay, good enough. Then technical errors. Machine faults. What might happen that the end-tidal carbon dioxide will increase?
Ma'am, if there is water
Rebreathing and
so there'll be
soda bicarb, ma'am, exhaustion of soda bicarb.
Okay, inadequate fresh gas flows are there, leaks in breathing, faulty ventilator, and so on. We need to go a little faster, I think. Then these will be the cause of increased end-tidal carbon dioxide. So coming to the decreased causes of decrease, again divide them into 4. When there is decrease in carbon dioxide output, that is when there is hypothermia. Perfusion, what will happen? What will decrease the end-tidal carbon dioxide?
Ma'am, any embola in the vessel, ma'am.
Yes.
Embola.
Yes.
And decreased cardiac output.
Yes.
And during manipulation of the thoracic vessels during major surgeries, ma'am.
That's because of hypotension, hypovolemia, because mechanically you are, handling it, and it can decrease the cardiac output.
Yes.
Then alveolar
hyperventilation.
You're talking about decrease, so it will be hyperventilation. Sure. Then
and any sample line leaks.
That comes in machine faults. Alveolar ventilation can be hyperventilation. Patient can have apnea. They can have airway obstruction. Then even maybe there is accidental extubation.
Yes.
Then coming to machine faults, what can happen? There is decrease in end-tidal carbon dioxide.
When there are
Occlusion of the tube, occlusion of the ET tubes, ma'am, or accidental extubation. I'm thinking of the tubes.
Done. So most of them we have covered. So now I have about 5, 7, because I don't want to take away Dr. Prasad's time from X-ray. So we'll quickly go through some 10 common, which in exam you'll be given the capnograms to, read. So this is the first one. Who's going to answer? Anybody?
This is a normal capnograph.
Normal capnogram.
Normal capnogram? Are you sure? But rate is low end tidal carbon dioxide with a good alveolar plateau it is. Okay, patient may be hyperventilating or increase in dead space. Tell me this.
It's elevated end tidal carbon dioxide with a good alveolar
hypoventilation.
Maybe due to
decreased
hypoventilation.
Right.
So if the cause will be maybe hypoventilation or increase of, like the number of causes we did for increase of carbon dioxide delivery to the lungs. What is this?
Curaric lefts, rebreathing coming out from the muscle relax.
So rebreathing and curaric left is different thing. So curaric left, what is happening? Patient
bucking. Patient is bucking.
Patient is out of muscle relaxation.
Okay. So how will it disappear?
After repeating a dose of relaxant.
Okay, so basically it is caused by, the action synchronicity that goes off between the intercostal muscles and the diaphragm because of inadequate muscle relaxation. That is why you get the notch. What about this?
Spontaneous breathing.
Rebreathing or in the sample line collection of ETC carbon dioxide, ma'am.
Spontaneous breathing attempts in ventilated patient.
Yes, because this is totally dyssynchrony between the ventilator and patient's breath. So it may happen in any part of the capnogram. You can see the breathing. It has occurred once in between the two. Then along the phases, a patient is taking the breath. So basically, it is spontaneously refers during mechanical ventilation. There are small breaths at various places. So it can be maladjusted ventilator, inadequate paralysis, or patient is waking up. Now, what is this?
Obstructed.
Pin shift.
Bronchospasm.
Why? Why are you telling it's bronchospasm?
Alpha angle got increased, ma'am.
Prolongation in the expiratory upstroke, ma'am.
Yes. And inspiration is taking place before expiration has occurred. That is why it has become little lower also. So there's another name, appearance it is called? Shark fin. Basically, an expiration is progressively prolonged and inspiration may start before is complete. So the end-tidal carbon dioxide also reading is decreased. So it is seen in obstruction of the tube or patient's airway, COPD or upper airway obstruction. Now, what is this?
Rebreathing, ma'am.
What are the causes? Why it's rebreathing? Because it is not reaching the baseline. Yes. What are the causes for rebreathing?
Ma'am, if there is an incompetent
exhaustion,
valve,
one by one.
Incompetent expiratory valve, and if there is insufficient fresh gas flow and soda bicarb like canister absorption, ma'am, if the soda lime is not adequate.
Exhausted.
Anything else?
And if there is addition of carbon dioxide to the fresh gas flow line, ma'am, if there is, we can identify deliberate addition.
And there is insufficient fresh gas flow also.
Yes.
So basically exhausted absorbent, insufficient fresh gas flow, problem with inner tube of vein circuit, deliberation addition of carbon dioxide to fresh incompetent valves, and rebreathing under drapes of a spontaneous patient. Okay, what is this?
This ROC.
It's return to spontaneous ventilation, ma'am.
How is it happening? It started small and then gradually came up to a normal one. So first breath is small volume and subsequently higher peaks. What is this?
Esophageal intubation, ma'am.
Everybody agrees?
Yes, ma'am.
Correct. What is this?
Cardiac oscillations, ma'am.
No, cardiac oscillation, I have not put it here. Cardiac oscillation, it will be, like a sawtooth and will go down. This kind of tricky one.
Extubation, ma'am.
No. Actually, when the tube, sometimes comes out or it is in hypopharynx and the air goes both in the stomach and the lungs. Or if you have ever seen the surgeon's hand is on the chest and with the pressure you may get it. So basically what happens is an irregular plateau or baseline may result from displacement of the tube in the upper pharynx or lower pharynx with intermittent ventilation to stomach and lung or for pressure on the chest, which causes small volume of gas to move in and out of the lungs. This normally will not be kept in exams so frequently. It's not one of the common ones though. So that is it. Tell me this one.
Ma'am, if there is a leak in the sampling line during positive pressure ventilation, ma'am.
What happens? Why there is a hump here?
If there is a circuit leak, there is gradual increase in EtCO2, so that will cause the increase in a third phase, ma'am. That causes the hump.
And this is because of leak in the sample line. So whenever positive pressure is there, then undiluted gas is forced inside, and that is why we get the hump. So what actually happens is that during positive pressure will return. There's an upswing in the end of phase 1. So a plateau of long duration is followed by a peak of brief duration. So why this brief peak is caused? Because this positive pressure pushes undiluted end-tidal gas through the sample line. That is why we get a peak. There was a leak there. Then there was a positive pressure. When there was a positive pressure, it pushes the undiluted end-tidal gas through the sampling. That is why we get that hump. So that this one will be, there'll be a leak in the sample line. So you saw one with the obstruction. You see how you saw hyperventilation, you saw hyperventilation, you saw rebreathing, you saw obstruction, you saw leak in the sample line. These are the most common ones which will be kept in the exams. Tell this. I have just another 5 minutes to go. Most important capnogram for us.
Accidental extubation, ma'am. Connection failure, ventilator failure.
Yes.
Ma'am, it is an exponential fall, ma'am. So it might be because of circulatory arrest or sudden hypotension.
That was the upper one. The second one, what is there?
Disconnection of the tube.
So you have circuit disconnector, accidental extubation. You can have a ventilator dysfunction, respiratory arrest, cardiac arrest. Anything else?
Embolism, ma'am.
Embolism, or there may be an obstruction in the sample line also. So we need to keep a wider this thing and first of all check whether the machine is okay or not, and then go one by one and exclude. So again, circuit disconnection, extubation, apnea due to ventilator massive pulmonary embolism, cardiac arrest, or obstruction to capnography sampling tube. So lastly, we'll come up to what are the uses of capnograph in OT, ICU, CPR. Tell me in OT what all you can use it for.
Blood pressure.
Do you use capnogram first thing for blood pressure in OT?
Ma'am, confirmation of
endotracheal intubation.
That is the first goal. Then what else?
It can also rule out esophageal intubation if there's a esophageal intubation.
Yes.
And
again, that comes in correct placement though.
Ma'am, and in case of Can be used in case of needle placement during transtracheal cricothyrotomy, ma'am.
So that will come in ICU.
Okay.
Or honestly, or otherwise using it as an emergency. Okay, what else?
Awake fiber optic intubation, ma'am.
In OT, if end-tidal carbon dioxide is high, what do you people do?
You hyperventilate.
Hyperventilate, ma'am.
What are you trying to do? You are seeing the end-tidal and you are changing your ventilatory strategies depending
To
upon
monitor ventilation.
So you monitor the ventilation, then you titrate your minute volume according to that. Then it can ensure your integrity of the breathing system also. Okay, what else? You can adjust your in laparoscopy. What you can do?
If it's going up because of increased carbon dioxide, we can again change the parameters like hyperventilate, and there can also be insufflation.
Yeah. So it can detect your venous carbon dioxide embolism also, and in Olden for blind nasal, which normally not done, you can guide it. Even DLT placements also it has been used. Now, what is the use in ICU?
Again, to monitor the ventilation, ma'am.
Yes.
Also intubation over there as well. And then hemodynamic.
Sudden cardiac arrest.
And then if the CPR quality, if you are giving CPR to arrested patient to assess quality of CPR and if ROSC has been achieved.
So how much would you like to keep the ETCO2?
If it should be at least 10 for good quality compression. And if it's 30, that means ROSC has been achieved.
So basically ideal is 10 to 20. And if it is less than 10, that means our compressions are not good. Okay, what else? What else you can see? ROC ho gaya, correct tube, both correct placements of tube, and even when you're changing the position of the patient and all, it can help you. So basically we are using in OT for confirmation, adequation of ventilatory status, titration of mitral minute volume to keep the ETCO2 in range of 35 to 40, ensuring the integrity of breathing system, adjusting the fresh gas flow, guiding blind nasal intubation, DLTs, detection of venous carbon dioxide embolism, and diagnosis of events like pulmonary thromboembolism and hypometabolic states. ICU is similar, as only thing what we added was percutaneous dilated tracheostomy, where you can confirm the intratracheal placement of the catheter, apnea test in dead patients, and otherwise similar like cardiac output and tube kinking and placement and all. And CPR, as we said, like we can see the ETCO2 and see the return of spontaneous ventilation. Dr. Prakash, Dr. Prasad, would you like to add anything?
Ma'am, can you brief on apnea test, ma'am?
So actually I will need to, exact to tell you, I will need to do it. I'll get back to you that how many, actually you remove the endotracheal tube, you disconnect. Okay, then you wait for some time. And then you can see whether the, wave is there or not after some time. So, but there is a factor for it, which I will just let you know. Meanwhile, little doctor.
20 minutes or something.
Yeah. So exact, I don't remember the time period, that I will let you know. Anything else?
Okay, ma'am. Thank you, ma'am.
Would you like to add anything to it?
Madam has covered the things comprehensively and what is necessary for exams. And it was in a short period, Madam has done it a wonderful job. Thank you, Madam.
I think I have taken half an hour now. Over to you, Dr. Prasad.
Okay, thank you, Madam. My screen is visible. Hello?
Yes.
Yeah.
Yeah, it's visible.
Video. Good evening. So now we'll be taking the chest X-rays. In examination, you'll be given chest X-rays, and you'll be told to read how to read an X-ray and to identify what is the problem. The most important step is to go in a systematic way rather than going hodgepodge. So when you get X-ray has been given to you, you have to go in a very systematic way. So the first and foremost, when X-ray is given to you, just one minute. Change your tongue, just 1 minute, please.
Sir, use arrow keys, sir. So you are mute. Prasad sir, you have to unmute yourself. You are on mute now.
Hello, am I audible now?
Yes, sir, you are audible.
Yeah.
Just click. Yeah. Sir, just go to home, sir, once. Yeah.
Home.
No. Just click on that transitions. Sorry, you go to slideshow, sir. Slideshow. Just enable editing and slideshow. Slideshow. Next. Up. Yes. After animation. Slideshow. Sir, slideshow.
1 minute, just a minute.
Okay.
Resume share. Just a minute. 1 minute.
Sir, click F5 button if you are not able to find F5 button. Yes, sir. Now you have to unmute yourself and speak. Rest all set, sir.
Yes, 1 minute, sir. Hello, am I audible?
Yes, sir. But you are not visible, sir. Prasad sir, just turn on your cam.
Yeah. Now, sir, it's okay?
Yes, sir. Good to go.
Yeah. Now, when an X-ray has been given to you, one of the most important steps is you have to find out is the X-ray what you're saying is of the correct patient. You have to see the identities like the IP number, etc. Once you're sure of that, very important step is to identify the site. Whether it's you have to identify the side of the X-ray. Most of the times, the side is marked on the X-ray, like right side, left side. Next slide. Like right side or left sided. Sometimes accidentally this marking will not be there. So in that case, you should know how to identify the side. So the most important steps to identify the sides are the apex of the heart, the gastric shadow, and the aortic knuckle. So by this we can identify this is the left side. But most of the time this side will be marked on this side. Once the X-ray has been given to you, apart from this, the very important steps are when you are evaluating X-ray, you have to evaluate the X-ray on two basic terms. One is technical evaluation and the other one is anatomical evaluation. So the most important step is the technical evaluation, because if the technical evaluation is not done properly, then you make a wrong diagnosis. So in technical evaluation, there are 4 important things that has to be technically evaluated. The first thing is you have to identify whether it's what type of view it is, or the projection, whether it's a posterior anterior view or it's anterior posterior view. So most of the time, again, it will be marked here like PA view, but in many X-rays, it may not be marked. You should be able to identify whether it's a PA view or it is a AP view. So these are the different projections common in X-rays: PA view, AP view, lateral debicutus, oblique, and other views. But commonly for anesthesiologists, we commonly encounter the PA view and AP view. most important is PA view. In PA view, the X-rays, the rays pass from posterior to anterior, and the film is kept in front of the chest. Whereas in a AP view, the rays are passing from the anterior to posterior, and the film is kept posteriorly. So how to differentiate a PA view and a AP view? These are the two films here. The one on this is the PA view and this is the AP view. Now, when X-ray has been given to you, how to identify whether it's a PA view or AP view? The first and the most important step is in a PA view, because there will be anterior rotation of the shoulders, the scapula will not be visible in the lung fields. It will be seen in the lateral side of the periphery. Whereas in a AP view, the scapula will be seen within the lung fields here. So this is one of the most important steps to say whether it's a PA view or a AP view. The next important step is the clavicle. When you take the clavicle into picture, it is within the lung fields here. Whereas in a AP view, it projects upwards. And the other thing is, there will be a clear distinct markings of all the lung fields and the cardia. In a PA view, it's not so very distinct here. And in a PA view, the posterior ribs are better seen, and whereas in AP view, the anterior ribs are seen. So these are some of the differences to say whether it's a PA view or a AP view. Once you're sure it's a what type of view, next thing is that this is a table showing the difference. Most important thing is the scapula, clavicle, ribs, and one more thing is in AP view, the cardia appears magnified, very important. But here it appears in normal shape, size. Next, once you are sure about what type of view it is, then you have to know whether this film is normally, patient is normally positioned during X-ray or patient is rotated. Whether you have to know whether it's a rotated film or it is normal. This can be identified by noting the distance of the sternoclavicular joint from left side and right side. Usually the distance from the sternoclavicular line to midline, it is equal. Whereas in a rotated film, this distance will be not same. For example, here, the distance is more on the left side when compared to right. So this is a right anterior oblique rotation. If the distance is more on the right side, it is left anterior rotation. Once you know about the rotation, next important thing is you should know whether this film is optimally exposed or overexposed or underexposed. In an optimally exposed radiographs, you can see the ribs through the heart here. You can see the ribs through the heart, and the spines are barely visible through the heart here. And pulmonary vessels near the edges of the lungs. You can see the pulmonary edges near the lungs here. So this is optimally exposed. Whereas in overexposure film, you can see the vertebrae here, and the lung fields are very dark here. But here you can't see anything here. You can only see, you can't see the vertebrae, the ribs, anything here. So this helps us to know whether the film is optimally exposed, underexposed, or overexposed. The fourth point for evaluation, technical evaluation, is you should know whether this is an inspiratory film or an expiratory film. For this, you have to count the ribs. In a fully inspiratory film, you can see the posterior ribs up to 10 can be counted, and the anterior ribs, you can see 6 anterior ribs. Here, 1, 2, 3, 4, 5, 6. And posteriorly, if you count the ribs here, for example, here, you can count the ribs here. 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9 to 10 ribs will be visible. So if in film, you can see about 9 to 10 posterior ribs and 6 anterior ribs. So this helps us to know this is a reasonably good film. So criteria to say this is good film is the sternoclavicular distance should be equidistant from midline. And coming to mediastinum, the right side is 1/3 and left side is 2/3. Lung apices are clearly seen here. We have vertebrae are seen in the upper cervical vertebrae are seen here. Diaphragm at 8 to 10 ribs, posterior ribs, and 5 to 6 anterior ribs. And the costophrenic angle and the cardiophrenic angle should be clearly seen here. And scapula should be away from the lung fields. It's here. And vertebral body should just be visible behind the cardia. And intervertebral disc and anterior should not be seen. So this is the criteria to say the film is reasonably a good film. Now, once you are technically sure about what type of X-ray it is, you have to make the anatomical evaluation. In anatomical evaluation, you can read X-ray from the inside out, from here, from inside out or outside in. So both are correct. It depends upon which you are familiar with. But to not to miss anything, you can go in a systematic way like A, B, C, D, E, F. A stands for airway. Here, this is the airway, trachea. This trachea, usually it is in the center, as you all know. And as it comes here, the sternal angle, it divides into anterior, into right and left. You have to evaluate whether the trachea is centrally placed or whether it's deviated to right side or left side. Next, once you evaluate the trachea, then B. B stands for the bony cage, bones, and also soft tissues. In soft tissues, you have to evaluate for any brush shadows or gas. Sometimes in subcutaneous emphysema, you can see gas here. So all this has to be evaluated. In bones, you have to evaluate the clavicle, whether it is properly placed and the apex of the lung is above it, or any fracture is there. And about the ribs, you have to see the posterior ribs and as well as the anterior ribs, any fractures. And this are obvious. Ribs are usually obliquely placed. In a AP view, it is horizontally placed. So you have to evaluate the ribs. And finally, you have to comment about the vertebrae. Vertebrae are seen, the upper cervical vertebrae are seen, and vertebrae are not just visible behind the cardia. Once you make the comment about the bones and soft tissues, next C stands for cardia. So cardia, first thing is you have to comment about the position of the cardia. When it is in the midline, 1/3 will be on the right side and 2/3 will be on the left side. Then once you comment about the position, you have to comment about the size of the cardia. This cardia is usually less than 50% of the thoracic ratio. The cardiothoracic ratio less than 0.5. Next, once you make the size about the size, you have to comment about the borders. The left border is made up of, here you can see the aortic knuckle, pulmonary conus, left atrium, and the left, sorry. And this is the left ventricle. The right border is made up of superior vena cava and the right atrium. And sometimes you can see the inferior vena cava here. So you have to comment about the borders of the heart. And once you are sure about the next after the cardia, you have to comment about the diaphragm. Diaphragm, in relation to diaphragm, you have to see whether it's the diaphragm on the right side is usually about 1 to 1.5 centimeters, 5 centimeters when compared to left side. And you have to comment about the cardiophrenic angle, costophrenic angle, and you have to comment about the gas under the diaphragm, the gastric shadow, and if there is any gas under the diaphragm, it implies there is a hollow viscous perforation. And to find out whether the diaphragm is flattened or doomed, here at the highest point of the dome, you have to draw a tangential line here, and at the same time a parallel line joining the cardiophrenic and costophrenic angle. If this distance is around 1.5 centimeter, it is normally placed. If it is more than 1.5 centimeters, it is doomed. If it is less than that, it is flattened. Because this helps us in diagnosing various conditions. Flattened diaphragm you see in emphysema. So it's very important to know whether the diaphragm is flattened or doomed. And very important again, I want to stress again is about the costophrenic angles. There will be blunting of the costophrenic angles, pleural effusion, etc. Then once you know about the cardia, then you come for E. E is any other extra things like an endotracheal tube, central line, a pacemaker, a intercostal drainage tube, any of the other things apart from the what is normally seen, you have to comment about E. Then F stands for lung fields. When you come for lung fields, normally, as you know, the right side we have 3 lobes, on the left side we have 2 lobes. But radiologically, we define lung fields based on zones. The upper 2 anterior ribs, upper to here, this is the anterior ribs, upper 2 anterior ribs is at the level of the sternal angle. You comment it as the upper zone, and 3 and 4 upper ribs, anterior ribs constitute the mid zone, and the 4th and 5th and below, this constitute the lower zone. And at the same time, you can draw a line at the midclavicular point to again differentiate into medial and lateral. So whenever you're commenting, you have to comment about these zones. what is the pathology. Next, when you want to comment about the lesions, very important thing is you have to know various densities, how it appears. For example, now in a normal X-ray also, the cardia is half white in color, the lungs are jet black, is black in color, and the bony cage bones are usually white in color. So this differentiation of color is due to the various variation in the densities. So now, for example, here I am showing here, for example, if the lungs are filled with water, it is a cardiac, it appears whitish in color. So you can say, we can see a cardiac-like density in the lungs. That is cardiac color. So when a fluid is there, it appears white in color. So this is very important. And finally, you have to comment about the bronchovascular markings. So this is about the lung fields. Once you finish the lungs, then you have to comment about the mediastinum, whether mediastinum centrally placed or it is deviated, it is pushed or pulled, depending upon the situation. And the hilar region. Finally, you have to comment about this hilar region, whether the vessels coming out, you're seeing the vessels, and also the peripheral vascular markings. So this is how you evaluate a given X-ray, the technical points and the anatomical points. With this brief introduction, I'll try to show some X-rays to you. We'll try to discuss how each one. So first, anybody, I think any student should come over and comment about this X-ray, please. Anybody, please? Hello? Am I audible?
Yes, sir. Yes, sir. You're audible.
Yeah, please comment. Any students can take part and comment about this given X-ray, technically and anatomically, please. Please take part. Hello? Coming to the technical points, what type of film it is?
Sir, somebody has replied PA view chest X-ray.
Yeah, very good. How did you say it's a PA view? Very important point is clavicle is not seen here. The scapula is not visible in the periphery. So you can say it's a PA view. And clavicle is below the apices of the lung. By this two, we can say it's a PA view. Then about next thing is it rotated or normal? Rotation, please.
Normal, sir.
Yeah, there is no rotation. Then about the exposure, optimally exposed, overexposed, underexposed.
Optimal exposure, sir.
Yeah, because you are saying the vertebrae just visible behind the cardia. So about optimally exposed. Then finally, you have to comment whether it's inspiratory film or expiratory film. You have to count the reps and tell whether it's inspiratory film or expiratory film.
Inspiratory film, sir.
Yeah, very good. Next, now we'll come to the anatomical evaluation. The first thing is trachea. Please, anybody? It is centrally placed. Sure, okay?
Yes, sir.
Yeah. Then about the bone and soft tissues. Soft tissues appear okay here on both sides. Then rib cage, clavicle appears okay. And ribs are okay. Comment about the intervertebral spaces. It appears okay, normal here. Next, coming to cardia. The position of the cardia, 1/3 right, 2/3 side, that is okay. Then about the size, the cardia appears smaller when compared when you take the cardiothoracic ratio. This appears little appears smaller, so it appears like a tube here. You can see this. It appears like a tube. It's a tubular heart. Clear?
Yes, sir.
Yeah. Then anything positive here again? Sorry. Cardia borders.
Both
border, it appears okay. Left border and right border appears okay here.
Yes, sir.
Now, yeah. Coming to diaphragm. Diaphragm, you can see here. This apparently it appears flattened. Ideally, you have to draw a tangent here, join this cardiophrenic and cosophrenic angle and see the distance. But apparently, it appears it is just flattened here. Okay. Now coming to field, lung fields. Lung fields are lung appear hyperinflated, jet black in color. Normally, it is black in color. Here, the lungs are jet black in color. So it is hyperinflated. And the bronchovascular markings are not very clearly visible here. We are not able to see any bronchovascular markings here. So the positive findings are tubular heart, hyperlucent lung fields, bronchovascular diminished, flattened diaphragm. What is the diagnosis? Hello?
Emphysema, sir.
Yeah, this is a classic example of emphysema. So next X-ray, anybody? Please comment technically and anatomically. Type of film, AP view or FPA view? It's a, please, this is a PA view because the scapula is seen away from the lung fields. The clavicle is okay. The apices of the lungs are seen here. So this is a PA view. Coming, next thing, is it rotated or normal? The distance here, it appears okay. So it is there is no rotation and it's a no rotation. Clear? Next thing is overexposed or underexposed. Please.
Adequately exposed?
Yeah, because you are hardly able to see. You can see the here the vertebrae here in the about 3 to 4. That behind the cardia are not able to see anything, so it is adequately exposed. Yeah. Next is inspiratory film or expiratory film.
Inspiratory.
Yeah, very good. Inspiratory film. Now coming to anatomical evaluation. Trachea. Where is the trachea here? You can see
midline.
Yeah, midline. Next, about soft tissue and bones. Soft tissue appears okay. Bones, clavicle is fine. The ribs are okay. Intercostal spaces are okay. Okay, so bony cavity, bony cage is okay. Next, coming to cardia. Hello?
Increase, sir.
Yeah, first is position. Position is 1/3 to the right, approximately, and 2/3, and it's more on the left side. So, yes. Yeah. And next is size. It is, it appears, yeah, the cardiothoracic ratio is more than 0.5. It appears apparently it is more than 0.5. Very good. Then positive findings. Other things. Borders. Any comments about the borders here, right side, left side? This border appears straight. Here you can see here, it's almost straight. And the right border appears okay. Okay?
Left ventricular.
Straightening of left border. We will come to that. What exactly is the pathology? This is straightening of, we'll find first is findings. Straightening of the left border. Then after the cardiac diaphragm appears okay. The cardiophrenic angle, costophrenic angles. You can see the angles here.
Yes, sir.
It's appear okay. D, E. Anything specifically you can see here? What is this? And you can see something here.
Central line.
Yeah, central line is going from subclavian. It is going into the interjugular. And this is a pin in the subcutaneous plane. This is here. The subcutaneous soft tissue. You have to comment about this. See, you can see this form. That is the pin. Okay. So coming to lung fields. Lung fields color is okay. And there is a, you can see this
pulmonary.
Yeah, you can see pulmonary vessels here on the right side. Left side is kind of difficult. Here you can see this. So this is most probably a case of mitral stenosis, straightening of the left border. You can see the prominent pulmonary vessels. Here, see here, what is happening is dilatation of pulmonary artery and dilatation of left atrium. So there is a straightening of the left border. Clear?
Yes, sir.
Yeah. So here, just I want to explain a little bit. Normally, what happens is this is the position of the left atrium. Here. So when this is the left atrial appendages. So in case of mitral stenosis, this get dilated here. So it joins here. At the same time, pulmonary arterial hypertension is there again. So this leads to straightening here. Clear? And here, is the position of the right atrium here. So that's that right side is usually formed by the right atrium, right border. You see, you can see the right border. And this is how the left atrium here. Here you can see that's why it's continuation from here. The left border is made up of the left atrial appendage and left ventricles. And this is how the right ventricle is. So in case of mitral stenosis, what happens is there is dilatation of this, and this goes posteriorly like this. And right atrium, there is hypertrophy and dilatation, and this comes anteriorly. So what happens when the left atrial dilates posteriorly and right atrium, there's hypertrophy and dilatation anteriorly, you get a shadow in the shadow appearance. In this, you may not be able to see a shadow in a shadow appearance. So you should keep that in mind. In case of mitral stenosis, you may see a shadow within a shadow appearance because of the dilatation of the left atrium posteriorly and the hypertrophy and dilatation of the right ventricle anteriorly, because in that you may see a shadow within a shadow appearance. And further, because there is a dilatation of left atrial appendages, it may push the left atrium upwards, left bronchus upwards. All these are the signs we should be familiar in case of mitral stenosis. Next, can anybody comment about this X-ray, please? Please, students, comment. Hello? What type of film it is? AP, PA? Hello? Am I audible?
Sir, Anchal Jain says it's PA.
Yeah, because scapula is not visible here, it's outside, and clavicle is with the lower to the apicus is here. This is basically a PA view. Yeah, fine. Then coming to rotation, is there any rotation? No, because this distance are equidistant. You can see here approximately it's same. About the exposure, please comment about the exposure.
Adequate, sir.
Optimally exposed, because you can hardly see, because you don't comment seeing the lung fields because the lungs may be hyperinflated. You have to comment seeing about the vertebral bodies. Just the vertebral bodies are just visible here behind the cardia. Here, this exposure is okay. Whether it's inspiratory film or expiratory film, count the ribs, but here it's not very clear here. It is difficult to count here from 1 posterior ribs, anterior 6 anterior ribs, and 9 to 10 posterior ribs. Inspiratory film, yeah. This is about technical, yeah. Next, coming to anatomical evaluation. Where is the trachea here? Comment about trachea, please.
Appear central, sir.
Yeah, appear central, okay. Then about the bony cage and soft tissue here. It appears okay here.
Yes, sir.
Yeah, bony cage. Ribs are okay, clavicle is fine, scapula and intercostal spaces, whatever intercostal spaces are okay. So bony cage is okay. Next, comment about cardia. 1/3 and right position is okay. It appears okay at least.
Yes,
Yes,
sir.
sir.
1/3
Next.
and 1/3.
Yeah, appears okay. Yeah, fine. Then size.
Normal.
Yeah, appears normal. Then borders.
Can be made out, sir.
Yeah, not, but it's okay. It appears okay, but not very clear at least. You can say like this. Okay, borders are okay. Next is coming to diaphragm.
Costophrenic angle, right?
Diaphragm pushed down, sir, right side.
Yeah, it's pushed down, right side. Yeah. Flattening of diaphragm on the right side. Very good. Then, sorry. Flattening is there. The angles are okay here. It should be still sharp. Okay, fine. And about the lung fields, it's jet black here.
Hyperinflated.
Hyperlucent, yeah. Hyperlucent lung fields. This is right, left side, it's okay. It is hyperinflated. And you can see here, just behind this hyperlucent, here, the collapsed lung, you can observe here, border here, like this. So, hyperlucent lung fields. So, now what are the positive findings? Hyperlucent lung fields, flattened diaphragm, and mediastinum. Coming to mediastinum appears okay. It's not very difficult to comment whether it is pushed or pulled. At hilar region, you can see the prominence here, and at the same time, you can see the lung fields on the right side, irregular opacity here. You can see here, irregular opacity. So what is the diagnosis now?
Right-sided pneumothorax, sir.
Yeah, right-sided pneumothorax with the opacity here. Maybe this may be a lymph node. We are not sure. It may be because this opacity is of that of cardiac. It is whitish, more whitish in color. Maybe lymph node. I think, and these are increased vascular markings here. With this, maybe edema around that lymph node thing. You can see this. So it is basically a right-sided pneumothorax. So next, anybody comment about this? Here, you can. This is the same X-ray of this patient. Here you can see intercostal drainage tube here. So now lungs are inflated better. The hyperlucency is gone. At the same time, the vascular markings you can see here again. So it's the same patient X-ray with a intercostal drainage tube. Next, anybody, please. Technical evaluation first.
Chest X-ray taken in PA view.
Yeah, good.
Rotation, it's not rotated.
No, yeah, no rotation. Yeah, very good.
Adequate exposure.
Yeah, adequate exposure. Yeah, good.
Taken during inspiration.
Yeah, very good. Yeah. Next, commenting
Trachea.
Trachea
Appears midline.
It appears midline. Yeah, fine here. It's coming down. Okay, fine. Okay, then trachea is fine. Okay, then about bone and soft tissue.
Appears normal.
Yeah.
Lung, left-sided lung is.
No, see, cardia. Come to cardia. ABC. To go in a systematic way. Don't miss anything. Okay. In the cardia, see, right. It should be 1/3 and 2/3. But here on the right side, it appears more. Left side is difficult to comment because of a dense homogeneous opacity in the left side. We'll come to that later. So the cardia appears more on the right side. And left side is difficult to comment. This is called still outing effect. One masking the other. One covering the other is called a still outing effect. Here, what is happening is because of a homogeneous shadow, the mediastinal border, the left cardiac border, the diaphragm on the left side is covered. It is called still outing of the left mediastinum, the left border of the heart, and the diaphragm. Okay, but only the positive comment about cardia is it's more on the right side here.
More on the right side.
Diaphragm. Coming to diaphragm, please comment about diaphragm. On the right side, it appears okay. Left side is difficult to comment because of the still outing effect. I told you, one masking the other. Because this is called still outing effect, very difficult to comment on the left side of the diaphragm. Clear?
Yes.
Yeah. Nothing extra you are seeing anything? No.
No.
Lung fields.
Lung, left-sided opaque lung field.
Homogeneous.
Opacity.
Cardiac opacity.
With a mediastinal shift towards right.
Yeah, mediastinal. No. First lungs. There is a homogeneous opacity or a cardiac opacity, you can say, because of this almost like same opacities is seen in the left side of the lungs, and at the same time there's a blunting of the
cardiac margin.
Costophrenic angle here. Here you can't see this border. No, costophrenic blunting of the costophrenic angle. Homogeneous opacity is seen here. Clear?
Yes.
And mediastinum is shifted to the right.
Right.
So what is the probable diagnosis?
Left massive pleural effusion.
Yeah, very good. Left massive pleural effusion. Next one here. Anybody next? Please.
Hydropneumothorax.
You should never jump to diagnosis. When an examination, an X-ray is given to you, you have to go in a systematic way. Please don't jump. I know everybody can be knowing the diagnosis, but you have to go in a systematic way. But that is a PA view or AP view. Plus, what is the view? Huh?
A PA view, sir. Chest X-ray taken in PA view.
Very good. How did you say it's a PA view? Because scapula and clavicle, see, apex you can see here. These are okay. Okay. So next, coming to, is there any rotation here? Rotation, no.
Slide.
Here, difficult to comment. See, it's coming. The border is here. The acroclamic, the sternoclavicular joint here. You can see this here. It's plus or minus. It's okay. Of course, there is some discrepancy here. Little here.
Yes.
Next, is there inspiratory film? Expiratory film?
Inspiratory film, sir.
Yeah, good.
And adequate exposure.
Adequate exposure, optimal exposure. Yeah, very good. Because you're not saying any vertebrae are just visible behind the cardia. Next anatomic evaluation.
Trachea appears midline.
Yeah, very good.
And
soft tissue.
Soft tissue and bones appear normal.
You have to see on both sides. Yeah.
And heart shadow on the left side cannot be made.
No, first thing, position is okay. 1/3, 2/3 appears. Okay. Yes, coming to the size, difficult to because left side because tilting effect. This is because it's masked. Yes. Tilting effect. It's difficult to comment on the left border and the left cardiac side. So it's difficult to comment about that. Then what else? Then
diaphragm, heart.
Yeah, diaphragm.
Diaphragm
on the right side.
Right side it is okay, and left side cannot be made out
because of the tilting effect. Okay. Yes. Okay. Then so there is a blunting of the costophrenic angle here.
Okay.
Yeah, coming to lung fields. Lung fields, you are seeing homogeneous opacity with the air fluid level. Air and fluid level. You are seeing air fluid level. This is straight line, and this is the air here. Air fluid level. Yes. Homogeneous opacity. Then here costo the peripheral vascular mass you can't see because of this mass. So what is the probable diagnosis here? Mediastinum appears
normal, central.
Yeah, not very okay. Yeah. Hilar region, you can comment about here, but we are not able to comment because of this tilting effect. Yes. So what is the most probable diagnosis here?
Hydropneumothorax.
Very good. This is hydropneumothorax. Left-sided hydropneumothorax.
Okay.
Anybody, please? Please comment.
So chest X-ray taken in PA view.
Yeah, very good.
No rotation.
Yeah.
Adequate exposure.
Yeah.
Taken during inspiration.
Yeah.
And trachea appears to be in the midline.
Yeah.
Bone and soft tissues appears normal.
Yeah.
Heart position is 1/3 and more on the 1/3 towards right and more towards left.
Yeah, enlarged rather, and size is enlarged.
Enlarged.
Yeah, and borders. You have to comment about the borders. Borders are very sharp.
Yes.
Okay, you can see this here. It's very sharp here, and more in the base. This size is more at the base. This is called as and the shape of the heart. You have to comment in this such condition the shape of the heart. What is the shape here?
Boat shaped.
Not boot shape, globular heart. Yeah, it's a globular heart. Sharp, enlarged globular heart.
Yes, sir.
Yeah. So, and at this next diaphragm, right side okay.
Normal.
Here, costophrenic angle is obliterated. It's difficult to comment because of this tilting effect.
Yes, sir.
Yeah. Cardiac diaphragm. Then anything you are saying? Nothing specific. Lung fields. Appears okay.
Yes, sir. Increased bronchovascular markings.
Here, yeah, you can see here. But otherwise, it's fine. Otherwise, so most probably diagnosis is
cardiomegaly.
How do you differentiate? I will say it's a pericardial effusion. How do you differentiate between pericardial effusion and cardiomegaly?
Borders, sharp borders are usually seen in pericardial effusion.
Then globular heart. See, the fluid always accumulates at the bottom. No, you can see more here. Globular heart. It's also called as old leather bottle appearance, or it's also called as ice bottle appearance. This is called. In cardiomegaly, you can see the borders and you can see the costophrenic angle here.
Yes, sir.
Yeah, here it's not seen. So this is a case of massive pericardial effusion. Very good. Next. Anybody?
Miliary tuberculosis.
Don't jump to diagnosis, please. Please go in a systematic way. Technical evaluation. What type of view it is?
It is a PA view chest X-ray.
Yeah, very good.
It's taken in an inspiratory film. It's an inspiratory film.
Yeah. Rotation? Is there any rotation?
Rotation is normal. Rotation is normal, sir.
There is no rotation. You should say, because the distance is no rotation. If there is rotation, there will be difference in this gap. Okay. No rotation.
Okay.
Exposure.
Exposure is adequate.
Yeah.
Then
this is about technical. Trachea
is in center.
Yeah.
Multiple nodules are seen in the
big bones. Please go in a soft tissue
soft
bones.
tissues appears normal.
Yeah, very good.
Multiple nodular like structures seen in the entire bilateral lung field.
Cardia. Comment about cardia. Go in the ABC.
Sorry.
Don't jump, please. Size of the cardia is fine. 1/3, 2/3. Position is okay. Size is okay.
Yes, sir.
Borders are okay. Yeah.
Borders are okay.
Yeah, very good. At least you have to come. Then diaphragm.
Diaphragm is normal on both the side.
You can see the costophonic angle here. Everything you are seeing. The diaphragm appears okay at least.
On bilateral.
Okay. Then coming to lung fields.
Multiple nodular like structures are seen in the bilateral lung fields.
Yeah. This
like
is
miliary tuberculosis.
No. These opacities of our cardiac color. So see, you can see the color. This color and this color matches here, no? At least see this cardiac. So, sorry. So there is a non-homogeneous opacities all over the lung fields. See, you can see all over the lung fields, please here. Okay. All over the lung fields. See, and this density and here, these densities are almost equal. This is a fluid-filled line. So it may be interstitial edema or alveolar edema all over the lung fields. Okay.
Yes, sir.
So what is the most probable diagnosis?
Miliary tuberculosis.
Tuberculosis, you get edema?
Or interstitial.
Interstitial alveolar edema, where do you get?
ARDS, sir.
Yeah, very good. ARDS. See, how do you say it's ARDS? ARDS is a non-cardiac condition. The cardia is also size is normal, position is normal. Whereas if you take congestive cardiac failure, cardia would have been enlarged, or pulmonary due to any cardiac cause, cardia would have been enlarged. See, ARDS is a non-cardiogenic pulmonary edema. So you can see this fluid infiltration into the alveoli interstitial fluid all over the lung fields. And in a congestive cardiac failure, what happens is you see more of a perihilar edema. Perihilar, that is called as bat wing appearance. Bat wing appearance you see in cardiogenic pulmonary edema, and in a pulmonary cause like this, you see ARDS. Okay, it's a classic case of ARDS. At the same time, you can see E. We forgot about ABC after lung field. E. You can see the center line here. Here, so you can see the line.
Yes, sir.
Yeah. So you have to comment about that E. Any extra things? Unitrachea tube is there? No, you're not seeing in a tube. Only this center line you can see here. Okay.
Yes, sir.
So this is a case of ARDS. No, anybody comment about this?
Congenital diaphragm.
First, you take here by one here, and we'll come to this later. At least this. Go systematically. Technical evaluation. Scapula not seen. Clavicle is positioned okay. Peer view. Next.
Trachea is in center.
No, please. No. Go to this whether
no rotation.
No rotation because the distance are plus or minus same. Exposure. You can hardly see the any vertebra here. Optimal exposure. Okay. Then
during inspiration.
Inspiratory film. Coming to anatomical evaluation.
Trachea midline.
And bony
and soft tissue.
Appears okay.
Normal.
Yeah. And cardia. Position 1/3, 2/3, and size and borders. Please comment.
Yes, position normal. Size also is normal.
Yeah, plus or minus okay. Yeah, good. Then after cardia, you comment about diaphragm.
Yes, sir.
Very important finding here is, what is this?
Gas shadow.
Where? Gas under the
Diaphragm.
What is this? Important. Gas under diaphragm.
Intestine.
Hollow viscous perforation. Basically, when you see comment about diaphragm, you comment on position, whether doming, flattening, claustrophrenic angles, and also should comment about whether if the gastric shadow will be here and the gas under the diaphragm. This is a classic case of
Hollow viscous perforation.
hollow viscous perforation. Clear?
Yes, sir.
Okay, very good. Anybody? Very easy.
Chest X-ray taken in
Yeah.
AP view.
How do you say it's AP or PA?
PA
view.
PA view, sir. PA view.
You should see where is clavicle here and scapula. You have to observe for the scapula here.
Kyphoscoliosis.
Yeah, of course. Diagnosis is very classic. It's a scoliosis. But when X-ray, and you can also, other positive finding is you can see the crowding of ribs here.
Crowding of ribs.
Yeah. See how they said crowding of ribs, and the spine is grossly deviated.
Yes.
These are the positive finding here. But please always go in a systematic way. Technical evaluation and anatomical evaluation. Okay. In bony cage here, you can say there is a there's overcrowding of ribs and the spine is deviated. All this. So this is a case of
Scoliosis.
Scoliosis. Yeah, very good. Anybody here?
So chest X-ray taken in PA view.
Yeah.
Rotation is present.
Is present. Huh? Yeah, well, because here difficult to comment because the scapula is appearing in the here, and this here is appearing somewhere here. So we may take it as rotation. This distance is more. So if this left side distance is more, then it is right side rotation, right? Anterior oblique rotation. Okay, fine. Then next, exposure. Lung exposure is
Adequate, optimal.
Optimal, yeah, very good. Then
taken during inspiration.
Yeah, sorry. Okay.
And trachea appears midline.
Yeah.
Bony fractures in the right side.
No. Trachea, then after trachea, yeah, bone. There's a fractures here, see?
Yes, sir.
How many? 3 or 4 ribs. And there is some opacities here. This opacities may be the fractured rib component, or it may be a foreign body because of trauma. Again, soft tissue here, what is this? Anything specifically can you see?
Emphysema.
Subcutaneous emphysema. You can see the subcutaneous emphysema here, please. Okay, very good. And bones are fractured. And this appears as small whitish tissue, like it may be bony, this fractured bone, or it may be a foreign body also. You don't know. Then what else? Positive finding. BC, cardia. Appears okay at least. But because of this here, right side, it appears little on the here. It's not exactly 1/3 on the right. Clear, okay. Difficult to comment about cardiac size, position rather. Size appears okay. And yeah, diaphragm. Is this here? What is this? You are not able to see the
claustrophrenic angle.
Blunting of the claustrophrenic angle here. So this is when there is blunting, you should think of fluid here. Then D, everything is fine. Then E, he can see these hooks. These are all E components. See nothing otherwise. He can see this component. These are all the hooks. Whatever. Then E, F, lung fields appears okay, but vascular markings are seen in the lower zone. That is okay, fine. F, lung fields, mediastinum, fine. Hilar region, you can see the vessels here. So what is the diagnosis now?
Rib fractures with
multiple rib fractures with subcutaneous emphysema and pleural effusion. Right side
effusion. Pleural effusion.
Clear? Good. Now, anybody?
Sir, we are running out of time.
Last thing, I think I'll conclude with the okay. Last one, it's okay?
Yes.
Yeah.
Right side
Chest
lower.
X-ray taken in PA view, no rotation,
Yeah.
adequate exposure,
Yeah.
and taken in during inspiration.
Yeah. Very good.
Trachea appears in the midline.
Yeah.
Bones and soft tissue. Bones appear okay. Soft
Yeah.
tissue.
Yeah.
Yeah. And cardiac 1/3 and 2/3.
Size. Yeah.
Size little tubular, normal, adequate.
Normal size.
And diaphragm on the right side is.
Yeah. Fine. See.
Yes, sir.
You see, diaphragm appears okay. This is the costophonic
Costophonic
angle,
angles.
cardiaphonic angles.
Yes, sir.
Diaphragm, and this is the gas, and this is the gastric shadow.
Yes, sir.
Diaphragm is fine.
And
Then,
nothing extra. Feels there is an opacity in
yeah.
mid.
And this, what is the density of this? It's almost cardiac density.
Yes, sir.
So it's a fluid filled homogeneous opacity in the lower zone of the lungs. Okay.
Yes, sir.
It's a cyst. And because the lungs you're seeing here, exactly the lower zone, you can see a homogeneous opacity, which is considered with the density of that of cardia, most probably a fluid-filled cavity.
Okay.
Yeah, so you can make a diagnosis, hydatid cyst or cavity, anything, whatever it is. It is just a fluid-filled cavity.
Okay.
So again, there are multiple, still more X-rays here. Because of the paucity of time, I'm concluding. Thank you very much. Any doubts, you can please.
Thank you, sir.
Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you very much, sir. Thank you, Namrata ma'am. Thank you, Prasad sir, for the session. Now, I will propose a vote of thanks for all the sessions. What a wonderful session we had. It is privilege to have such a wonderful master class from the master's teachers. It is my pleasure to propose vote of thanks on the behalf of organizing team, ISA Mangalore City Branch and ISA Karnataka. I thank Dr. Anand Bangira sir, Dr. Sudish Kannan, Dr. Jiki Divatia, Dr. Namrata Ranganathan, Dr. and Dr. CGS Prasad for not only sparing their valuable time for us, but also sharing their knowledge and experience in the subject. Thank you all the participants who participated wholeheartedly and enthusiastically and made the discussion lively. I hope all cleared your doubts and concepts. Knowledge will bring you opportunity to
Can we
make that.
see the classes in YouTube?
I am sure postgraduates benefited immensely from this masterclass. Once again, from the organizing team, ISA Mangalore and ISA Karnataka, I thank all the people who had made this event successful. Thank you.
Good evening, everyone. It was an excellent session, Namrata madam and Prasad. We actually really enjoyed your discussion. A lot of things were taught, excellently discoursed, projected, and involving the students. It was excellent. Even earlier speakers were very good. Dr. Anand Bangira, Dr. Sudesh, Dr. Divatya, and Dr. Tantri. In spite of technical glitches, it was wonderfully rendered. Thanks one and all, especially our participants were very good. It has definitely taken quality of the discussion to greater height. Thanks everyone. Thank you all.
Thank you, Shripal.
Thank you.
Thank you,
Thank you, Prasad.
Thank you. Thank you.
It was wonderful. Thank you.
Thank you.
Thank you, madam. Thank you.